కనబడుతున్నారు కనబడుతున్నారు సార్.
So, sir, is 3, 2, 1. Oh, sir, we are live to the attendance.
Good morning. We are again from FOGSI ICOG here, welcoming you all for this FOGSI ICOG PG Clinic program. This program is mainly for the students, how to appear in the exam. We create simulated situations. We have doll and dummy case discussions, and then master the skill. And in case discussion, the students present the case and the examiner discusses with them. So after that, in the end, we have a quiz on the topic. So we try to simulate the examination situation in this program. This program is conducted every second Sunday of the month. Every month we are doing it for last more than 4 years. And we are thankful to our FOGSI president, Dr. Bhaskar Pal, ICOG chairperson, Dr. Sheila Mane, for encouraging us and supporting this program. So we welcome you all. And today we have exciting program, and we will start with our esteemed teacher, Dr. Haresh Doshi sir. He will be describing the cephalopelvic disproportion, how to assess, diagnose, and what will be the management strategies when there is a CPD. After that, we have students from Andhra Medical College, Visakhapatnam. They will be presenting a case of preeclampsia. Dr. Sucharitha and Dr. Veda Shruti. And they are very well guided by the professor and HOD from Andhra Medical College, Dr. Somani. And we have expert teachers, as we have always, Dr. Ashish Mukhopadhyay, Dr. Vijaya from ESI Medical College, Chennai, Dr. Archana Kumari, professor from Rajendra Institute of Medical Sciences, Ranchi, and Dr. Sohani Bhattacharya, head from Jalpaiguri Government Medical College and Hospital, Jalpaiguri, West Bengal, and Dr. Sanjay Kumar Tambe, professor and head, BJ Government Medical College, Pune, Maharashtra. And in the end, we have Dr. Dipanvita Banerjee, senior consultant oncology from Chittaranjan National Cancer Institute, Kolkata. And she will be discussing about the how to tackle gynae oncology specimen in the exam. So, and in the end, we will have quiz on hypertensive diseases in pregnancy. So we welcome you all. We are thankful to all the faculty and students for contributing their valuable time for this program. And let me tell you, the recording of this program is available on the ICOG website immediately after the program. And similarly, we have our recording of last previous program also available on the website. So you can very well refer to those topics and take the advantage. So before we start, we have Dr. Sheila Mane, our chairperson. She is not available physically, but she has sent her message for the program. So Mr. Ramnath, can we have the message from Dr. Sheila Mane?
Yes, Saloni, video please.
Sir.
Good morning, everybody. I would like to wish all the best for today's PG Forum, CME. And I thank Dr. Ashok Kumar, Dr. Hafizur, and Dr. Ashish Mukherjee for this continuum of this PG Forum. Dr. Haresh Doshi will be talking to you regarding the labor, and all of you will really learn a lot, and all of you know that his books are so popular and it's very helpful for the PGs. I thank Dr. Ashish, Dr. Vijaya, Dr. Archana Kumari, Dr. Sohini, and Dr. Sanjay Kumar Tambe for being there as an expert today for the case discussion by the postgraduates from the Medical College from Visakhapatnam and Dr. Somini students. Thank you, Dr. Somini. Dr. Dipanvita Banerjee, who is going to take the class on specimens, which will be very useful from the examination point of view, and all of you will definitely benefit from it. And Dr. Archana and Dr. Mahima, they are going to conduct the quiz on today's topic, that is HTP, and I think all of you are already geared up. So, thank you, and please ask your colleagues and the fellow students to join this every time on second Sunday of every month for this FOGSI ICOG PG forum. Thank you.
Thank you.
So thank you, madam. And we have Dr. Parag Binewala, past chairperson, with us. Sir, most welcome.
Thank you. I just wanted to wish you all the best for the program. This activity
Thanks.
is going on for last 5 years plus, and I'm sure more and more students will be benefited by this continuum. So special appreciation to Dr. Ashok Kumar, Dr. Ashish Kumar Mukhopadhyay, and Dr. Hafizur for persistently spending their second Sunday morning of every month ICOG. Thank you.
Thank you, Dr. Parag. I will not hesitate to appreciate the efforts of my colleagues, Dr. Ashish Mukhopadhyay and Dr. Hafizur Rahman, in conducting this program for last 5 years. And obviously, ICOG office is always supporting the program. And we have Dr. Pratik Tambe, Secretary of ICOG, this time with us. So, Dr. Pratik, you wish to say something?
So good morning, everybody, and thank you for conducting this long-running FOGSI ICOG PG Clinic. My congratulations to the conveners, Dr. Ashok Kumar sir, Dr. Hafizur Rahman, and Dr. Ashish Mukhopadhyay, who have been the backbone of this program for so many episodes. As you heard, it's conducted on the second Sunday of every month. I congratulate all the faculty for giving their precious time and sharing their knowledge with us and with the students. And I hope more and more students join and benefit from this amazing teaching activity. Apologies for the poor quality of the audio video. I'm in Varanasi. Network here might be a little poor. I wish all of you all of the very best. And please continue. Don't stand on ceremony. Thank you for inviting me as well.
Thank you, sir. Thank you, Dr. Thank you, Dr. Tambe. And we are thankful to all our governing council members of ICOG also, and all our fellows who are always behind the curtain helping us for the continuity of this program. So thank you very much. And we start now with our first program of cephalopelvic disproportion by Dr. Haresh Doshi. And I request Dr. Hafizur Rahman to please continue with the proceedings and invite the teachers.
Thank you, sir. So as
before that, we have Dr. Ashish also with us. Dr. Ashish, would you like to say something before we
Ashish,
proceed?
sir,
Yeah,
Yes,
yeah,
sir.
I'm there. Am I audible?
Yes.
Yes, sir.
Okay, thank you very much, Dr. Ashok Kumar and Dr. Hafizur. In the 6th year of this PG Clinic program, I heartily welcome all the faculty members, the students, their coordinators, and the different medical colleges participating in this program. Very interactive program, and it is a benefit to many other PG colleges in the country. I would like to say that we are constantly evolving. Dr. Ashok Kumar has already said that the last addition in the program was the specimen discussion, which is useful. I'm getting the feedback from all the students now. And I hope we are going to add more and more new features in the program so that this is beneficial for the exam going students. And any more thing that you want to add, you are most welcome to suggest so that we can incorporate in the program. But it should be according to the NMC curriculum, NMC guidelines. So that is what I only desire. And finally, I would like to just have a query. I don't know whether Pratik Tambe has left or not. I just wanted to have some query about, the number of website visits by our students, if by any means it is possible to find out, because we are all frequently saying that all the programs are available in the website, and whether the students are really hitting that, getting benefited, I just wanted to know. So website hits are very, very important, and we are conducting this, online program webinar, but the storehouse of that is the website. So if it is possible by any means to know how many students are actually hitting the website to get the old editions, because there are certain things we have always conveyed and communicated about the format of history taking the examination and the presentation and the case discussion. So I would like to know that. And if it is possible, Pratik, kindly find that out. And Hafizur, please get in touch with him. If it is possible, we can find that out. I welcome all the faculty members. Our senior faculty member, Dr. Harish Doshi is there. Dr. Swamini is there. And many other faculties are there. I welcome all of you and best of luck for the students. Thank you very much.
Thank you so much, sir. Thank you, Ashish, sir. We would like to thank our FOGSI president, led by Dr. Bhaskar Paul, ICOG chairperson, Dr. Sheila Mane, madam. And we are very much thankful for allowing us to conduct this program for the 6th year. So I'm very much thankful to Ashok Kumar sir and Ashok for constantly supporting as well as guiding in the program. So without wasting any time, we would like to start the first session, that is on master the dummy pelvis. So in this session, today we are having one very important topic, which is will be taken by the author as well as Professor and HOD OBGYN at GCS Medical College, Dr. Harish sir. Sir will be taking on cephalopelvic disproportion, how to assess, diagnose, management, and management tips. So that will be very helpful to the students as well as for future career also. So we will go step by step by each program. So I'd like to request Harish Doshi sir to take over it on. Doshi sir, over to you, sir.
Yes. Okay.
Thank you, sir.
Is it coming full screen? Hello.
It's loading.
Yes.
Yes, sir, it's there.
Okay. At the outside, I must thank the FOGSI President and Secretary and ICOG Madam Chairperson Dr. Sheila Mane, Secretary Pratik, and three backbones, Ashish Kumar, Dr. Ashok Kumar, and nonetheless Hafizur. And I am a chronic repeater of this program, faculty for 5th time. Thank you, Hafizur, for constantly calling me.
We would like to have others in future as well. Thank you so much, sir.
Please. Sure. Okay. It is moving, not moving. Why not moving? Yes. So yes, I would like to discuss my topic under these headings: definition, risk factor, diagnosis, prognosis and complication, mechanism of labor, and management. As the words are self-explanatory, cephalopelvic disproportion occurs when there is mismatch between the size of the fetal head and size of the maternal pelvis, which results in failure to progress, also called as dystocia in labor for mechanical reasons. Dystocia literally meaning difficult labor and is characterized by abnormally slow progress of labor or failure of progress of labor. But today, most cases of dystocia result from malposition like occipitoposterior, macrosomic fetus, or from ineffective uterine contraction, the power part, or cervical factor, not only from cephalopelvic disproportion. Nowadays, the bony pelvis has got the backseat in the causes of dystocia. But what is classification of CPD? Borderline CPD is called when obstetric conjugate, which is the narrowest diameter of the inlet, not true conjugate, is less than 9.5 to 10 centimeter. When you call it severe disproportion, when the diameter is further shortened to less than 7.5 centimeter. Other definition of borderline disproportion is not practically used. We can do that. All cases in which the volume of the fetal head exceeds the volume capacity of the inlet, but by not more than 70 cc. Up till that it is there, but if it is more than that, there is a moderate or severe CPD, this proportion. There are some anatomical, for theory purpose, anatomical definition also of only of contracted pelvis, not CPD. When one or more diameters of the true pelvis is reduced below the normal by 1 or more centimeter. So 1 or more diameters, 1 or more centimeters. But if it is of true pelvis reduced, it is called contracted pelvis. But obstetrically, what is important is any of the diameter of true pelvis is reduced so as to alter the normal mechanism of labor for normal size fetus, which leads to complication, should be called as contracted pelvis. Originally, many years back, Caldwell and Molloy classified female pelvi, studying the female pelvis who have delivered normally. They found that there are 4 major types of pelvis. That is not much accepted now. Why? Because the pure types are rarely found. And this classification essentially describes shapes of the pelvis. While we are concerned with, for the delivery, we are concerned with the size of the pelvis. The central part is shows that these are 4: gynecoid, anthropoid, android, platyploid. What is important is these arrows, intermediate combination of these are more common rather than pure different types of pelvis. What are the etiological factors? CPD, so pelvis and cephalic, head, fetus. So one group is of fetal, large size fetus. It may be hereditary, constitutional, large size, parental size, racial, same thing, obesity of the mother, macrosomia, diabetes, particularly. Post-maturity, nowadays we find less because we induce the labor once the date is crossed. Malformation, again, hydrocephalus. Increased parity and increased age also leads to large size fetal head. Somewhat functional large, not actual large, occipito-posterior because of deflection, asyncretism because of tilting, that also present as a large diameters to the pelvis and may lead to CPD. Pelvis size. On pelvis side, so many causes are there. But in practice, we find it in a very less number of cases, very less, right? Developmental causes, Roberts or Naegele's pelvis, where congenitally one ella or both ella or sacrum are not developed. Nutritional, rickets, osteomalacia, that is vitamin D deficiency, malnutrition, calcium deficiency, any trauma or surgery of pelvis, diseases of bony pelvis, any tumor, infection. I put a star there because polio is one infection common. It can lead to lower limb and pelvic deformity, but not all polio cases lead to CPD. Some of the cases vaginal delivery is still possible. Disease of the lower limbs, right, affect because pelvis is that combining with the spine and the lower limb. Pelvis is in between. So any problem of lower limbs, pelvis or spine can lead to contracted pelvis or CPD. So disease of spine common: kyphosis, scoliosis, spondylolisthesis. The first figure, lordosis, because of lordosis, lumbar lordosis, sacrum is pushed inside. So AP diameter is reduced. Kyphosis, so tip of coccyx is pushed forwards. So it is outlet problem, right? Scoliosis, lateral tilting, again the side walls may be problem. So all this spine deformity secondary affects the pelvis and leads to contracted pelvis. Then how will you diagnose CPD? There are many things. For any medical condition, we have a history, symptoms, signs, and examination. So in history, you have a history of disease, right? Maybe polio, maybe rickets, maybe osteomalacia. Injuries, right? History of injuries to the pelvis. Surgery of pelvis, any surgery done on the pelvis. Past history of, if there is nothing is there, then if there is a history of difficult delivery, instrumental delivery, failed delivery leading to cesarean section, you must note down that history that this may be a case of CPD. General examination, short stature, less than 145 centimeter. Now, important, all short stature will not have CPD. Some of them, their babies are also small and they can deliver. See, the height of Japanese, Korean females are less, but still they have normal deliveries. So, but this gives you a clue that be careful, assess this short women's pelvis correctly. It may be little more than general population, the pelvis contracted. Gait. From the gait also you can make out, right? Gait is affected because of spine, lower limbs, or pelvic problem. Features of rickets, you know very well. Ricketic rosary, pigeon chest, right? Harrison sulcus, right? Bow legs. So all these can tell you features, history. Dystophia syndrome. There is a very peculiar syndrome where the female is short, obese, stocky, and with android type of pelvis, triangular inlet and all that, narrowing pelvis. Okay, so all this history is important. Coming to the examination. These are the clues. If in a primary at term, if you have a head which is high floating, in most than half of the primary, the head should engage right before the labor starts. So if it is a floating and high floating, then it tells you that maybe contract pelvis. Pendulous abdomen, same way, because it is floating, the abdomen comes forward. Malpresentation, again, that will tell you that it is, you are dealing with maybe contracted pelvis. There are clinical tests for CPD. We don't do this much, mainly because this detects only inlet, but they are important. And therefore, exam point of view, you must remember, they are done to detect inlet contraction. If the head is not engaged in primary at term, particularly primary, not a multipara, because multipara, you have a history of either delivery or failed delivery or cesarean section. You know the, right, her obstetric situation or pelvis. But in a primary gravida, for inlet contraction, there are two methods. One is abdominal and one is combined bimanual method. Pinard's and Muller-Munroker method. What is Pinard method? It is abdominal method. When you do that method, bladder and bowel must be empty. Patient is placed in semi-sitting position better. You can do it in a dorsal position also to bring the fetal axis perpendicular to the beam in a semi-sitting position. Semi-sitting. That's why. The left hand pushes the head downward and backward in the pelvis, while the two fingers of right hand are put on the pelvis pubis or are put on the symphysis pubis to detect the degree of overlapping and thus the disproportion. This figure is right there. Left hand pushing the head per abdomen and right hand two fingers over symphysis pubis to check the overlapping. This is Pinard, abdominal method of detecting CPD. Other method, Muller-Munroker method, bimanual. It is more valuable in detecting the degree of disproportion. Not only disproportion, but degree also. The patient is placed in dorsal position again. Left hand pushes the head in the pelvis. Left hand, and vaginal examination by right hand inside the vagina. The thumb is placed over the symphysis pubis to detect two fingers in the vagina, thumb outside over symphysis pubis, and then the left hand pushes it and check for disproportion. This figure is telling you this, right? Two fingers inside, thumb outside of the right hand, and left hand pushing the head inside to check for disproportion and degree of disproportion, right? Fingers in the vagina, the tip should be at the level of ischial spine. If you can push it up to the ischial spine, you can feel it below, then there is no disproportion. So that level of the internal fingers is important at the level of ischial spine. Not too much out, not too much in. Well, so many type of pelvimetry, right? For assessment of pelvis, because it's a CPD, you have to check with the cephalic, but pelvis absolutely also, separately also you must check. External pelvimetry gone, internal pelvimetry is there, X-ray pelvimetry, CT pelvimetry, imaging techniques, all now comes everywhere in our right practice. Sonopelvimetry, sonocephalometry, but believe me, right, only internal clinical pelvimetry is in our hand, important. I will deal with everything, right? All others are there for theory. Practice, we do only clinical pelvimetry, right? Only clinical pelvimetry. Okay. Having said that, the evidence from the literature and experience says that even antenatal clinical pelvimetry is of no value in primary gravida with cephalic presentation. In primary gravida only and cephalic presentation. Why? Because fetal head is the best pelvimeter. The true test of pelvic capacity is by trial of labor, retrospective. So 10 years back, Cochrane in 2017 did this systematic review, and they found that pelvimetry for fetal cephalic presentation at or near term for deciding the mode of delivery, thinking that finding out the CPD, 5 trials of 1159 women were included. Not enough evidence. They did not conclude. To support the use of X-ray or clinical pelvimetry for deciding on the mode of delivery in women whose fetuses have a cephalic presentation. And on the contrary, when this was done, more patients were subjected for cesarean section. It is like you are using electronic fetal monitor for assessing the labor. With electronic fetal monitor more used, more wrong distress was detected and more cesarean were happening without improving the perinatal outcome. Same thing here, more X-ray and clinical pelvimetry, and then they found from their study. But still, I would say clinical pelvimetry is important for your planning, management, informing the patient, informing the relatives, everything. Pelvimetry by MRI. This is used to assess the dimension of the pelvis because it assesses the soft tissue very nicely also. The baby's position, examination of the soft tissue of the mother as well as the baby. But it is costly, naturally, and time consuming and not available to everybody. It is like taking a sword rather than knife to cut the apple. Big thing for a small purpose, right? But it is definitely better than manual examination, ultrasound or X-ray pelvimetry, CT pelvimetry, and non-radiation hazards. So MRI, when it becomes very cheap, okay. Otherwise, today its role is very limited. Okay, coming to the pelvis, all measurements are essentially static. It's a bony pelvis. But having said that, the pelvis is not a single solid bone. It's comprised of many bones held together by cartilages and ligaments. You can see in this figure, right? All ligaments, right? This is important. So during pregnancy, this soft tissue attachment become more pliable, elastic, allowing considerable movement and space. This is important. Movement gives you space. Sacrococcygeal movement, this figure, it can go backward and then outlet can increase. So squatting position, also opening up the pelvis, right, at the outlet level. So squatting, squats, and duck walks and all this we tell the patient in last trimester so that they can have easy normal delivery. So this is same thing working on the pelvics and pelvis diameters, because even though pelvis is a bone static, right, but ligaments and other things make soft tissue, make it more pliable, gives some little more space for vaginal delivery. Labor is a dynamic process. Always remember this, right? In practice, right, you will have experience of, right, primary gravida, even primary gravida delivering fast, 4 hours, 5 hours, 6 hours, and like that. So you have to match everything, pelvis, passage, passenger, power, everything, okay? Then coming to soft tissue resistance, right? Pelvis may be good, but soft tissue, cervix is a very hard form, not dilating. Pelvic floor, rigid perineum, okay? So that is a problem. My teacher used to tell me that if you want to become a good obstetrician, you must develop friendship with cervix. Meaning, you must learn how to assess the cervix. Cervix is the only organ from 0 to 10 centimeter, it dilates in few hours. That is a great thing for nature, right? The pelvis is static, contractions are coming, time taken for pregnancy, baby, uterus enlarging. Cervix dilates only during labor, 10 hours, 8 hours. And that's why you must assess the cervix nicely. Thickness, softness, right? Stretchability, exit dilatation, everything, then you will be a good obstetrician. Power, uterine contraction, 200 Montevideo is called, right? Adequate power, Montevideo units. Voluntary muscles is a secondary power, and that also has the same strength as primary power. So always consider that also. Nice sentence is given by Professor Sasher-Moore, right? Good uterine contractions are worth half a centimeter of pelvis. It gives you that half, because of molding, and that baby can deliver with good contraction pushed. So one of the author of Munrokat operative obstetric textbooks, very right, great faculty. But he has nicely mentioned that good uterine contractions are worth half a centimeter of pelvis. Coming to the passenger, baby itself, fetus, right? Fetus also has a role in dystocia. Degree of flexion, deflex, larger size, dimension, it is CPD. So cephalic dimension changing because of some reason, the pelvis may be same, but problem. Rotation, again, right? Transverse position. Asynclitism, lateral tilting, all these, and molding. Minimal molding, no, with good molding, not pathological molding, but vaginal delivery can happen. So this is important, right? That power, passage, passenger, everything is actually CPD is for passenger and passage, but power is also important. And here this is a passenger. Okay, so the clinical pelvimetry, important tips. What are the tips? It should be done beyond 37 weeks only. Some soft tissue relaxes. Better at the start of labor. Most important time. Bladder and bowel should be empty. Patient made to lie in dorsal position with thighs slightly flexed, well separated. Explain the patient. Priming, it is first time, painful. You tell the patient, this is 2 fingers. I only will introduce 2 fingers. The same passage is for the whole baby, 10 centimeter baby to come out. So it will not be much problem. But relax, right? Make her relax, counsel her adequately, and then gradually assess, starting from going posteriorly in the whole of sacrum. Don't go anteriorly first. It will be more discomfortable to the patient. Take full aseptic precautions, always. Complete scry, because after PV, you may introduce infection rather than assessing. And most important is, when you do PV, do complete examination. Not removing the finger, then you, oh, I forgot to assess the sacrocytic notches. No, keep the fingers inside, note down, ask the sister or assistant to note down what is the right inlet, cavity, outlet, then all other obstetric parameters, cervical dilatation, effacement, presenting part, membrane, caput, molding, everything, station. But pelvis also has many points. You must, right, completely assess and note down before you remove your fingers from the pelvis. I teach my students that there are inlet, cavity, and outlet at all level. You have to check three things, but you can narrow down to 6S. For inlet, sacral promontory is important, right? You can assess by diagonal conjugate, and that I will take later on. But inlet, nothing more further. Cavity, you have 3 things: sacral curve, side walls, and sacrocytic notches, right? It will tell you about the cavity. For outlet, you have last 2 things: interspinous distance and subpubic angle. So 6S. Promontory, curve, side walls, notches, ischial spines, and subpubic angle. 6S will tell you the whole pelvis. Right. So how to assess, right, the promontory, inlet, epidiameter. For practical purposes, if the middle finger of the examined hand, right, reach the sacral promontory, you have a problem. If it does not reach or reach with difficulty after lowering the, see, I will show you in the pelvis, right? Yes. After lowering the hand, if I have to lower my hand for this, then what happens? Then it is a good dimension, good, right? I will show you like this. Okay. So this, going from here, lower motor, but then I have to depress my elbows it is a good AP diameter. That gives you diagonal conjugate. You have to deduct 1.4, half an inch from that to get the true conjugate. From 12 centimeter, you have to deduct 1.5. Right, okay. Not done if the head is engaged because it is for inlet, right? AP diameter of inlet. So if head is engaged, head has entered the pelvis. Same thing, the other figure, right? How can you exactly measure that? You can do this and then put a other finger's hand to mark out on the gloved hand, gloves, and then outside you can take on the measure rule, right? Foot ruler or anything. So that, but you know, your fingers dimension are not changing. So I know it is 10.8 centimeter. So that is right. I have to do that in that sense. Interspinous not always narrow if spines are easily. Interspinous not, I'm sorry, not always narrow if spines are easily felt. That is thin patient. Distance between the spines rather than prominence matters. It is not the right prominence. Thin patient, you can feel the spines, but it is the distance between two spines. And keep the dorsal surface anterior. That's how you may not separate. This figure shows that you cannot separate it in a dorsal way. But if you do like this, you can do any dimension by this. But like this, you cannot separate the figures more. Right. Okay. Another clues, other tips for pelvic metry. Obese patients, side walls appear converging because of soft tissue. Right. You have to actually assess the pelvis, bony pelvis, and not the soft tissue. Primary gravida, again, rigid perineum may mislead you. Rigid perineum may mislead you. Uncooperative patient, sometimes levator and eye contracts, voluntary contraction, and giving you resistance and problem. So that is there with uncooperative patients. So these are the tips you must keep in mind when you assess the pelvis. Again, I repeat, actual bony pelvis is to be seen. Now, right, subpubic angle. If it is more than 2 finger, right, it is supposed, right. If you 3 fingers, very good subpubic angle, but less than 2 finger, it is narrow. Less than 2 finger, it is narrow. It is narrow, right? Okay. You can do the subpubic angle by other means also, like this, right? Okay. This is subpubic angle. If I can put my 2 fingers and assess it, it is narrow. If I have to require thumb and that is, the figure tells you, this you can stretch more. Fingers you cannot open more. You have a limited, right, dimension for fingers. But for, right, okay, this you can. So if you require your thumb and index finger, it is a good subpubic angle. If you require only, right, fingers, you can check the subpubic, right, inferior pubic rami, then it is, right, it is narrow subpubic angle. See, this figure tells you, we know that in inlet, transverse diameter is more, in outlet, AP diameter is more, in cavity, it is a circle, 12, 12, 12 everywhere. So what is important is, for practical purpose, if AP of inlet and transverse AP of inlet and transverse of outlet are adequate, the whole pelvis is adequate. So it's a simple clue, right? Because you know the dimension of the pelvis. See, summary for pelvimetry, pelvic assessment. Grossly contract pelvis is rare. We don't find much grossly contract. Borderline disproportion is increasing. Pelvic assessment guides the planning and management of labor. Clinical assessment should be done in the beginning of labor. After 37 weeks, better after the onset of labor. Pelvic assessment by the progress of labor. It is a retrospective assessment. And again, I'm repeating, fetal head is the best pelvimeter. Okay. So without appropriate training and practice of this clinical skill, pelvimetry, it is in danger of becoming a lost art. I've seen my SR who have obtained the degree of MS Gynec, and still they are not accurate fumbling at clinical pelvimetry and telling me, sir, this pelvis is not good, we will take her for cesarean section. When I examine, I tell, no, this is not that. Baby is also average size, and many a times vaginal delivery happens. So that this is in a danger of becoming a lost art. You must, as an obstetrician, it is said that cesarean can be done by surgeons, but it is the obstetrician who can do the deliveries. Now, this only one slide for mechanism of labor in different pelvi. In gynecoid pelvis, it is head engages inlet, it is transverse or oblique position, engagement no difficulty, anterior rotation occurs, whatever degree remaining, delivery can happen. But anthropoid, anteroposterior, long pelvis, the inlet is in inlet engagement occurs in a direct anteroposterior position of the fetus, and posterior rotation happens or non-rotation happens. If it is directly occipito-posterior, delivery can still happen with a good anthropoid pelvis. Delivery is still possible. It is face to pubis delivery. It is face to pubis delivery. Face is coming first, and then baby is delivering. Right. So that is face to pubis delivery in anthropoid. Android pelvis is a problem. It is the head engages in the occipito-transverse or posterior position. Engagement is difficult and delayed. It may remain as persistent occipito-posterior at a cavity or deep transverse arrest. So either you end up in cesarean section or difficult instrumental delivery. If you are doing, it's okay. Pilan, nobody is doing them. I am doing somewhat, but otherwise, the difficult instrument delivery is gone nowadays. Mid forceps delivery is gone, and only lift out outlet forceps people are doing. You cannot do in transverse arrest. So better cesarean section, but this is a problem. This CPD mechanism is excessive caput molding can happen. Platyploid, transversely flat, occipito-transverse position, naturally it engages. The engagement may be delayed. It happens with acyclidism, that lateral tilting, I will show you. With lateral tilting, supro-subparietal diameter, not BPD, but with lateral tilting, supro-subparietal diameter. So that is 8.5 or less, not 9.5 BPD. And that's why with asynclitism, this can happen. That first tilting and then asynclitism, supro-subparietal diameter. It is delayed because of this with asynclitism, and it remains that position transverse, because they're transversely, long pelvis, platyploid, flat pelvis. So it goes there. Only at the outlet, the rotation occurs, anterior rotation, very low down, but delivery can still possible. So delivery is good in normal, sometimes happening in anthropoid and platyploid, arrest in anthroid. So all these different mechanism, because normal female can have this pelvis, more than 50% is gynecoid, but these are less than, all three together, less than 45%. And in some anthropoid, platyploid, delivery can happen if you wait. If FHS are good, you can give trial of labor. In android problem, arrest may happen. So new evidence has come, but there is not much useful. And 8 years back, this is the 3D camera platform they did in Ethiopia, Gleason Arrow assessed the risk of obstetrical labor due to CPD. And novel scalable approach, but it was not much, The results were not that applicable in general population. So camera system you require. And fetal-pelvic index, one is this, FPI, combines the fetal's head circumference and abdominal circumference, HC plus AC, with comparison with pelvis, maternal inlet and outlet measurement total. If it is positive FPI index, it suggests if fetal HC plus AC is more than maternal inlet plus outlet, it is positive FPI, fetal-pelvic index, it suggests CPD. When it is negative, it is less fetal dimensions, naturally, the suggests that head is smaller than maternal pelvis and delivery can happen. So fetal-pelvic index, again, there was a study in 2015, but clinically much useful or prediction of CPD or not, right? Proved, and that's why we are not using it routinely. But for theory purpose, you must remember what is feto-pelvic index and what is 3D camera system for assessing the CPD. Okay. Well, what are the problems, complication, right? Increase with CPD, what happens? Increase incidence of operative deliveries. Nowadays, cesarean. Very less people are doing instrumental delivery. Very few people, right? And that is also a lost art. Cesarean section, left and right. Undiagnosed or untreated CPD lead to many complications. Difficult and traumatic instrumental delivery. If you bang upon this, then it may be problematic. Obstetric labor, it leads to undiagnosed and all its sequelae. What is the sequelae? Sepsis, hemorrhage, rupture uterus, difficult cesarean, everything. That you know very well. Nowadays, we give less trial and people very easily recourse to cesarean section in early labor. That is a wrong thing. But when you give a long trial, that is also a wrong thing. So you have to be very proper judgment and give proper trial of labor. Perinatal mortality, morbidity increases, obviously, and rarely maternal mortality can happen. Well, management, last point, for gross disproportion, elective cesarean after 38 weeks is the answer. For borderline disproportion, trial of labor is planned. What is trial of labor? It is conduction of spontaneous labor, not induction. In a borderline CPD, in an institute, under supervision, all these criteria. It is a test labor putting all the variables, passage, passenger, and power into test and determine whether vaginal delivery is possible or not. Progress of labor is assessed by partograph. Nowadays, we have LCG, Labor Care Guide by WHO, some different components, 7 components, but at least partograph by the progressive descent of the head, and original partogram was for these two purposes, dilatation and descent, right? So that still stays here and you must remember. Trial is carried out in hospital, full facility for immediate cesarean section, kneel by mouth, analgesia, try to avoid prom, right? By rest in bed, avoiding high anemia, minimum PV examination, careful monitoring, better electronic fetal monitoring and partograph record naturally, augmentation of oxytocin if required. What is important is allow proper time for labor to happen. These are the old, right, time slots, but still useful. What is prolonged later phase in nullipara more than 20 hours, multipara more than 14 hours. What is important is this arrest of dilatation and arrest of descent. When you call it more than 2 hours and more than 2 hours, more than 1 hour, adequate contraction should be there for this. More than 200 Montevideo units, 10 minutes. For 2 hours, this contraction should come. Then and then you can label it as an arrest of dilatation. Not immediately after half an hour, you can go for cesarean section, right? Okay. So with epidural, time is always 1 hour more, that we know very well. So protracted is no problem, but arrest, you must accurately act and right, take the patient if required for cesarean section. Well, nice guideline says, Larry listen, 2023, active phase starts at 4 centimeter dilatation. Regular painful contraction and progressive dilatation from right. While American College says 2024, updated, 6 centimeter. Again, they came out with 6 centimeter some years back. Still endorsing that 6 centimeter active phase. We follow 4 centimeter and the LCG also produced 4 centimeter. Upper limit of second stage also increased by ACOG from 2 to 4 hours in nulliparous woman if maternal vitals and fetal heart sound are good. And this we have seen in some patients. If you give trial, everything is good, delivery can still happen. But normally we go with this 4 centimeter as the active phase of labor. In woman with cephalic presentation, unless there is gross disproportion, a well-conducted trial of labor is the best test of adequacy. I mean, repeating this, but it's very important. Well-conducted trial, right? Unless there is a gross disproportion. Okay. New evidence, it was hypothesized that simple placement of peanut ball between a laboring woman's legs could increase pelvic dimension and allow more room for fetal descent, right? That is American College 2016, it appeared. More trials are awaited. Still, how this works, this is, you can have this. In labor also, first stage of labor, patient can have this, or at last few weeks of pregnancy, practice this, and that squatting position type thing, or increases the dimension, and delivery is facilitated or somewhat easy as compared to. So this is one more preventive aspect. University of Pennsylvania, innovative alternate method for active management of risk in pregnancy at term, AMOR IPET. This method advocates preventively inducing early induction of pregnant woman according to presence of risk factor. First, you check the risk factors. If they are there, then you induce the patient. And it is associated with the risk factor which are associated with impending CPD. You must induce the woman, and that is called AMOR IPET trial. Again, not very much accepted, right? But it was there in nulliparous women at term, right? CPD, preventing CPD. Okay. So future obstetric management, if trial of labor is successful, vaginal delivery is done in next pregnancy if fetal weight is not much higher. Naturally, this time it was successful. The second time you can try. And particularly when the weight is not more, must try. Even if trial of labor has failed, cesarean section is done. Tolek may be tried if the second pregnancy, if the baby weight is less. Evidence says that 65% of those having CPD as indication of first CS can deliver, approved by evidence, vaginally second time, Tolek, right? This is important. Okay. Thank you very much. Hello, Hafizur.
Thank you
Yes,
very
sir.
much, Professor Doshi. Thank you very much. A very elaborate discussion on management of CPD, diagnosis of CPD, and also beautiful practical tips for conduction of labor management. I think these are old golden rules about obstetrics, and you have done it very elaborately, and you have started your journey from the ways we used to be taught about the undergraduate and postgraduate teaching till present day with evidence-based medicine. It was wonderful, sir. Thank you very much.
Thank you,
for
sir.
your excellent deliberation on this, and elaborate, and you have finished in time also. Although cephalopelvic disproportion, basically we were taught about the disproportion at the inlet level, but you have traveled through the pelvis and taken the baby successfully out. And you have defined all the criteria and aspects of the vaginal delivery. Thank you very much. And I wish that a group of students, the present generation students, will follow your advice and go for the trial of vaginal delivery. It is very much needed today, because the one way we will shout about the increasing rate of cesarean section, and the other direction we will just neglect this advice, or we don't follow this up. That will not serve the purpose. So that is why your lecture was really, really path-breaking. Thank you very much, sir.
Thank you, sir.
Thank you. Sir Doshi, sir, before we move into the next session, I think 1-2 minutes, Dr. Soumya Srivastava has put a question to you. What is the difference between contracted pelvis and CPD? You just can, maybe they would like to hear from you, sir. What is the difference between contracted pelvis and CPD?
Yes, CPD is cephalopelvic disproportion, so it is relative. If the pelvis is normal, say, and the head is big, it is CPD. If the pelvis is small and the head is normal, still it is CPD. But contracted pelvis, I gave the definition, anatomical definition, and obstetrics. So it is only one component, isolated, pelvis, right? If the pelvic, any diameter is shortened so as to alter the mechanism of normal labor in a normal size fetus, it is contracted pelvis. But we have to always consider CPD, right? If the pelvis is normal size, but the head is, the baby is 4.3 kg, then it can lead to CPD. So it is related, both simultaneously. We are concerned with that coming out of that baby from that pelvis. So CPD. But contract pelvis isolated is right only with the definitions. Okay,
in
sir.
other words, in a contracted pelvis, a head can enter, but in a CPD, the head cannot enter. So that is the basic difference. That means the assessment of very important thing that whether
Yes.
the head will be able to enter into the pelvis.
Yes.
That the decision is actually taken by CPD assessment, whereas contracted pelvis can be an isolated assessment without taking regard of the passenger.
Maybe.
Thank you. Thank you so much, sir, for your excellent deliberations. Horace Doshi, sir, and I know whenever in some different or special topics, sir, there I always lean on to you and you always agree. Thank you so much. And I would like to have it in future as well. Thank you so much.
Thank you.
So now we'll move to our next session. That is another important session which have been constantly and consistently there from the last 6 years. So that is this session on case discussion. So this month we are having the team from Andhra Medical College, Visakhapatnam. So they are going to have a case on preeclampsia, and the students are Dr. P. Sucharita and Dr. Veda Shruti Behra, both are third-year postgraduate student, and they have been very aptly guided by their professor and head, Dr. G. Somini Madam. So for this session, I'd like to have the faculties, the expert faculties all over from India. First, Dr. Ashish Mukhopadhyay sir is always there. He's principal and professor at CSS College of OBGYN at Kolkata. Then we have Dr. Vijaya. Madam is professor at ESIC Medical College and Hospital, Chennai. Welcome you, madam. We have Dr. Archana Kumari. Madam is professor at Rajendra Institute of Medical Sciences, Ranchi.
Good morning, sir.
We have Dr. Kahini Bhattacharya, madam. Madam is professor and head at Jalpaiguri Government Medical College, West Bengal, Jalpaiguri. Welcome, Kahini, madam. And finally, we have Dr. Sanjay Kumar Tambe, sir is professor and head at BJ Government Medical College, Sasun General Hospital, Pune, Maharashtra. So I'd like to welcome all the faculties, and at the same time, I'd like to invite the students, Dr. P. Sucharita and Veda Shruti, to share your presentation and request the faculties to take over to examine the students.
Sir, thank you, sir. I sincerely thank the Indian College of Obstetricians and Gynaecologists for giving the rare opportunities for our students from Andhra Medical College to present their definitely an invaluable opportunity for the postgraduates to share, to gain the knowledge, and to have the expert opinion from you. Thank you so much, sir. I thank you.
Thank you, madam.
Yes, sir.
Best as well as our students. Yes.
Thank you, sir.
Dr. and Dr. Veda, and to all the faculties, please.
All the respected professors, a very good afternoon to everyone, sir. Myself, I'm Dr. P. Sucharita, third year postgraduate from Andhra Medical College, and she is my colleague, Dr. Veda Shri Behra. Today, we are going to present a case of preeclampsia. Ours is a case of 22-year-old Mrs. X, who is a wife of Mr. Y, who has been married for 1 year in a non-consanguineous marriage, resident of Srikakulam, which is approximately 2 hours distance from Visakhapatnam. She is a homemaker by occupation, and her educational status is 10th standard. She belongs to a low socioeconomic class. She is a primary 8-month gestation who is booked elsewhere, that is a private hospital Srikakulam, and her date of admission is June 6 of 2026. She has been referred from the private hospital Srikakulam in view of high BP recordings, that is 160 by 100 millimeters.
Am I audible?
Yes, madam.
Yeah, just go to the first slide. Yes. What is the importance of age?
Because less than 19 years or more than 35 years is a high risk factor to develop hypertension in pregnancy.
Okay. What is the importance of the duration of the marriage?
Exposure to the sperm causes again increased risk for the preeclampsia development.
No, I didn't get you.
Less exposure to the sperms or new paternity can be a cause of preeclampsia.
Okay. And is there anything with the low socioeconomic status?
Previous malnutrition can also be exposed to comorbid.
No, come closer to the mic. No, not able to hear properly.
Yes.
In the low suction of class, there is a chance for malnutrition, madam, which can be a risk factor for hypertension and other comorbidities related to pregnancy.
And the mother must be also born as a low birth weight. So it is also again a risk factor, madam.
Okay, so she's a primate, right? She's a primate. Can it develop in the second gravida? Can preeclampsia or hypertensive disorder, can it come in the second gravida?
Yes, madam. But
How,
there is.
who are all the second gravidas can get exposed to the risk of HTP, hypertensive disorders of pregnancy?
The large interpregnancy interval, madam.
Yeah. So definitely the reducing factor are the cohabitation. The more they stay with the husband, the same husband, there is a reduction in the hypertensive disorder. Okay. A long interpregnancy interval. Second,
exposure to new paternal genes. That is,
yeah, she marries again. Yeah, the new paternity is also important. Okay, go to the next slide.
Dr. Vijaya, hello.
Excuse me.
Good morning, Dr. Vijaya.
Sir, good morning.
Yes, good morning. Good morning. It is nice that you have started this question from the first slide, and there are some discrepancies also I can see. That they have written about the distance. Very good that they have written the distance from the home where they have to have the obstetric service, but approximately 2 hours from Visakhapatnam doesn't make any sense. Whether you travel by car or a bullock cart, or what is the what is the method of conveyance. So that is important. That is why the kilometer should be written. Okay, but personally I feel that madam, let them present fully. And then after finishing their presentation, we can go for the crossing. Is it okay? Otherwise, their flow will be affected. And we also see the presentation skill of the students in the examination, isn't it? So that is possible. And you can note down the discrepancies or the mistakes or omissions, whatever you see in each slide. And then in the end, after presentation, we can ask them to go back to the slide.
Okay,
I think that will be better. That will be better. Okay. Thank you. Thank you.
So can I have one query?
Yeah, you have one. Yes, Archana.
Just one. So I just wanted to ask, why have you mentioned the gestation in terms of month and not in terms of weeks? When she is sure of her LMP, I think. Actually, you have mentioned quickening at 5th month, 8-month gestation. Nowadays, we always refer period of gestation in terms of weeks. That is the only thing I wanted to highlight.
Actually, see, my logic will be that whenever the patient presents, the complaint should be recorded as per patient's voice, isn't it?
Patient's
Whatever
voice.
the patient says.
So
Yes.
8 months of amenorrhea, that is better than putting it as 8 months gestation.
Yeah. Actually, it's the patient person, so you can accept that. But when you're presenting the case as summary, then you must convert it into the weeks. That is better, isn't it? So as long as there is patient's complaint, we can accept that.
Yes.
So we will now reserve the questions till their presentation is complete, and I request every faculty to kindly note down the obvious differences and discrepancies and add the questions. Okay, I think Veda was continuing. Veda, please continue.
Mrs. X, 22-year-old primary gravida with 8-month gestation, was referred from a private hospital, Srikakulam, in view of high BP recordings, that is 160 by 100 millimeters of mercury, and headache since 2 days with a referral slip. There is history of pedal edema, history of progression up to grade 2, no diurnal variation since 3 weeks, history of headache, which is occipital, severity not relieved by hypertension, no history of visual symptoms, that is scotoma, bladdering, diplopia, no history of epigastric pain or right upper quadrant pain, no history of nausea, vomiting, no history of convulsions, no history of bleeding per vaginum or leaking per vaginum. She is pursuing active fetal movements and referred in view of imminent eclampsia. She was apparently normal 2 weeks ago and had her regular antenatal visit, during which her BP recording was 140/90 millimeters of mercury with a urine albumin traces and pedal edema since 1 week. Further, she was admitted there for 2 days, evaluated and diagnosed with gestational hypertension. Her investigations were like this 2 weeks back, that is HB 10 grams per deciliter, platelet 2 days, which were within normal range. According to the records available with the patient, her BP recordings were under control with tablet labetalol 100 mg BD. And then she was discharged after explaining and counseling regarding BP monitoring and imminent signs. Again, she went to the same hospital with complaints of headaches since 2 days, which are not relieved with medication. And then her BP was recorded as 160 by 100 millimeters of mercury, and the urine dipstick test done, which shows a 2+ albuminuria, and the baseline investigations were repeated. On eliciting history, the patient said that she didn't took medication for the past 3 days. Then she was given injection labetalol 20 milligrams IV and injection magnesium sulfate loading dose for seizure prophylaxis, and referred to King George Hospital, Vishakhapatnam, which is a tertiary care center, with the referral slip attached. At that time, her investigations were like this, which were mentioned in the referral slip, that is HP 10 gram per deciliter, platelet 1.4 lakhs, creat 0.8 milligrams per deciliter, SGOT PT of 40 and 38, viral negative, VGTO positive, uterus corresponding to 36 weeks, which is relaxed, and fetal heart is present. At admission, that is at KGH, her BP was 150 by 100 millimeters of mercury, urine albumin plus. She complains of headache since 2 days, which is sudden onset, dull type of headache over the occipital area, which is not relieved with medication. Also, the patient has history of swelling of feet, which is not relieved with rest since 3 weeks. For menstrual history, aged menarche 13 years. Menstrual history, she bleeds for 5 days every 30 plus or minus 2 day cycle. Cycles are regular, which are painless and progress. And last menstrual period is 25th of September 2025. The patient is sure about her dates. That makes the estimated delivery date July 2nd, 2026, corresponding to a 37 weeks period of gestation. Coming to the OBS history, she is a primary gravida. In first trimester, she conceived spontaneously, confirmed by urine pregnancy test in 2nd month of gestation at home. Folic acid was taken regularly. No history of any other drug intake or radiation exposure. No history of excessive vomitings, fever, rash, burning micturition, spotting per vagina. Her BP recordings were normal as per her previous records done by the ANM. Testosterone score 2. Second trimester, quickening felt at 5th month. 2 doses of TD were taken. She was advised routine baseline investigations and anomaly scans, which were normal according to the patient records. She took calcium, folic acid tablets regularly. BP recordings were normal as said by the patient, but no proper documentation is available with the patient. Was screened for gestational diabetes, which was negative. Third trimester, she is perceiving active fetal movements. Lab iron and calcium were continued regularly. Throat scan was done in 8-month gestation, which is normal according to the patient. She had complaints of pedal edema since 3 weeks. And then she was diagnosed with gestational hypertension in 8th month with the BP recording in the private hospital and started on antihypertensive medication. She had complained of headache since 2 days, which is not related with medication. Past history, no history of hypertension, diabetes, thyroid disorders, jaundice, bronchial asthma, TB, epilepsy, cardiac disorders, liver or kidney disorders. Family history, there is no similar history in family, in mother or siblings. No history of any chronic diseases in family. And there are no history of any congenital, genetic, autoimmune disorders in the family. Dietary history, she takes a non-vegetarian diet. By 24-hour recall method, her calorie intake is 1900 kilocalorie and protein intake is 46 grams per day. There is both calorie and protein deficit. Personal history, she is a non-alcoholic, non-smoker, normal sleep pattern. She had normal bowel and bladder habits. No history of any allergy, food or medication.
General examination. Patient is conscious and coherent, well oriented to the time, place, and person. She is moderately built and nourished. Her height is 154 centimeters. Her weight is 64 kgs, and BMI falls on 21.7 kg per meter square. She has grade 2 bilateral pitting type of pedal edema. There are no signs of pallor, icterus, sinuses, clubbing, lymphadenopathy. There is no chelosis, no glossitis. JVP is not raised. Thyroid appears normal. Bilateral breast is normal and soft, which is non-tender. Spine appears to be normal. Her vitals are, she is afebrile and pulse rate is 90 beats per minute taken in the right radial artery, which is of good volume and which is regular in rhythm. There is no radioradial or radiofemoral delays in the right hand. Respiratory rate, it is 18 breaths per minute. BP is 150 by 100 millimeters of mercury measured on the right arm in sitting position. Her saturations are 98% on the room air. Urine output is 500 ml, which is clear, and urine albumin is 2+ measured in dipstick method. Systemic examination, her respiratory system, bilateral vesicular breath sounds are heard, no added sounds. Cardiovascular system, on inspection, no chest deformity, no dilated veins, no pulsations in the left parasternal regions. On palpation, apex beat is displaced upwards and it is heard on the left fourth intercostal space, and no parasternal heave or no palpable thrills. On auscultation, S1 and S2 are heard. There are no murmurs. CNS, higher mantle functions were normal with no sensory or motor deficits and no exaggerated reflexes. Obstetric examination. On inspection, abdomen is uniformly distended with umbilicus central and everted, linea nigra and stria gravidarum would present. No visible scars or sinuses are seen. On palpation, uterus is firm with flank fullness with symphysiofundal height of 34 centimeters, abdominal girth of 38 inches. Uterus is relaxed and it is non-tender. Obstetric grips. Fundal grip, a soft, broad, irregular mass is felt which is suggestive of breech, and lateral grips, smooth, curved, and hard on left side, which is suggestive of back, and knob-like structures are felt on the right side, which are limbs. And first pelvic grip, a smooth, hard, ballotable structure is seen, which is suggestive of fetal head. Second pelvic grip suggested that the fetal head is engaged as the fingers are diverging. Liquor appears clinically adequate. Estimated fetal weight is 3.5 kg according to the Johnson's formula. No organomegaly. On auscultation, fetal heart sound heard along the left spino-umbilical line, 145 beats per minute, which is regular, and non-stress test is done, which is reactive. And on pervaginal examination, cervix, it is 4 centimeters in length, which is mid-position with medium consistency. Os, it is stiff admitting, presenting part vertex at -2 station. Pelvis, it is gynecoid, adequate for this baby. Bishops, it is 3/13. My summary. Mrs. X, 22 years of age, primi gravida at 37 weeks of gestation, referred from private hospital in view of high BP recordings with imminent signs and is admitted for further evaluation and management in HDU setup. On general physical examination, grade 2 bilateral pitting type of pedal edema is present. Her BP is 150/100 millimeters of mercury with urine albumin of 2+, and her cardiovascular and respiratory systems are normal. On obstetric examination, uterus corresponding to the term gestation with flank fullness with singleton live fetus and cephalic presentation. Liquor appears adequate. Uterus is relaxed. On auscultation, fetal heart rate is 140 beats per minute, which is regular and heard on the left spino-umbilical line. My provisional diagnosis, Mrs. X, 22-year-old, primi gravida with 37 weeks period of gestation with singleton pregnancy in cephalic presentation with late onset preeclampsia with severe features. She is not in labor.
Okay. So now that you have reached the end of presentation, provisional diagnosis is the end of your presentation. Do you have any differential diagnosis, or should we start this thing crossing from now only, on the basis of your presentation? Do you have any differential diagnosis?
The patient has already been diagnosed with gestational hypertension, sir. Since it's a case of peripheral, because of imminent symptoms, we will diagnose her as a preeclampsia.
Okay. So do you think a diagnosis of gestational hypertension, that's what she was diagnosed with, is it appropriate? Or you want to have a different diagnosis of preeclampsia, or it can be other aspects of the preeclampsia syndrome, okay, like HELP syndrome, or it may be some other diagnosis. Do you have any such diagnosis in mind?
Sir, at the diagnosis, the patient was diagnosed with gestational hypertension after confirming that there is no proteinuria or there are no other signs of end organ damage, and they have also done laboratory investigations, sir, which were with normal liver function tests and renal function tests. So I think it is appropriate that they have diagnosed it as gestational hypertension, sir. But because the patient is not compliant to the medication in the last 3 days, she might have developed high BP recordings because of that, and she might have developed preeclampsia syndrome.
It is a rapidly progressive disorder.
So the proteinuria was there, no?
Sir, at the diagnosis, it was not there, sir. It is only traces, sir.
Okay. So your difference, if the provisional diagnosis is gestational hypertension, the differential diagnosis can be preeclampsia, isn't it? So that's why I asked you what was the differential diagnosis. Anyway, so Dr. Vijaya,
Yes,
now
sir.
I'm coming to you, madam. Do you observed any discrepancies in the recording of the history or general examination or local examination?
Can you go back to your slides, please?
Yes, ma'am.
Go back to the first slide and
Yeah.
it's one by one. Go advance one by one.
Yeah, second one. Yeah. See, now suddenly the patient had swelling of the legs. That's what you said, no? So when will you be bothered if the patient comes with pedal edema?
Pedal edema is a normal pregnancy feature, which is mainly occurs in the third trimester.
Physiological. So pathological edema, when will you say it's pathological edema?
When the edema is seen in non-dependent areas and it is not relieved with rest.
What are those areas? Non-dependent.
Like face, hands, abdominal wall and vulva are the non-dependent areas.
Sacrum. Okay. Okay. And not relieved by rest. Okay. And also if there is a sudden appearance of pedal edema, all these while she was coming to you, it's good and she's all right. And suddenly she said, my legs started swelling. So the sudden appearance of pedal edema and there is a sudden increase of weight gain. Those 2 points will put you on alert. Okay. Okay. Then the second month you did UPT. Did you do UPT in the second month? I saw somewhere like that. Yes, go to the first slide or second slide it is.
No,
urine pregnancy test was confirmed in the second month or something. Yeah, this slide, first trimester. Urine pregnancy test. When will you confirm your urine pregnancy test?
After the missed period, actually the patient should check, madam, the urine pregnancy test, and patient should actually arrive to the hospital with a complaint of she's not getting her period, but the patient didn't turn up at the right time. She only
doesn't take the pregnancy test by kids at
home. But she has done it at home, right?
Yes, ma'am.
Now you didn't do it, okay? How early you can do the urine pregnancy test?
4 weeks. After 14 days of conception, the urine test usually will be positive.
Tell me after the missed period. We don't know the conception date and all. Unless it is an IVF, we won't know the date of conception, right? That will be an excellent data if they conceive by IVF. So now the patient has come with missed period. How early the urine pregnancy test can become positive? It's an easy question.
Within a week, madam. 5 days after the last menstrual, 5 days after the last menstrual period, she can get a UPT positive.
4 to 5 days after the last menstrual period. Now the recent things, even on the day of the missed periods, more sensitive PREC card has come. So even on the day of the missed period, it becomes positive, right? So the first trimester she has come and you have done the gestosis score, right? So what gestosis score will put you on alert?
More than or equal to 3 will put me on alert, madam.
So which are the conditions are given straight away 3?
Chronic hypertension or any prior renal over diabetes or chronic renal disease.
Diseases, history of thrombosis.
I didn't get you. Renal disease,
yes, madam.
Diabetes then?
Diabetes, prior hypertension, chronic renal disorders, autoimmune diseases, history of thrombophilia, and
also the
donor
IVF with the donor. Yeah, that is very important. IVF with the donor. And what are the few things that have come newly? All the risk factors, you know, young primate, old primate, all those things we know. So much about this hereditary thrombophilia, latent mutation, everything we know. The new things that have been added to the risk factors, one is the thyroid. Okay.
Hypothyroidism.
Yeah. And the second one is a psychiatric illness. Patient is on antidepressants, selective receptor, serotonin receptor blockers. That is also added newly. And GDM. These are the 3-4 things that has been added new to the gestosis score. Apart from that, the risk factors, what we have learned previously, still says. Okay. So having come in the first trimester, if a gestosis score is more, could you have done anything?
Yes, madam. I use the uterine artery Doppler to check the pulsatility index, madam. And
when will you do? What are the times you will do?
Madam, first, if she has a gestosis score of 3 or more than or equal to 3, then I'll also do a combined screening, madam. In that, I'll see her mean arterial pressure after assessing the maternal risk factors. Then I'll also be seeing her uterine artery pulsatility index and placental growth factor levels, madam. If there is any high risk obtained, then I'll start the patient with tablet aspirin 150 mg at bedtime.
Stop with it. How will you measure your normal blood pressure? Tell me first normal blood pressure, then we can go to mean. Ashish sir, you can interrupt anytime. I'm just going in a flow. Anytime, sir. Archana ma'am, you also, ma'am, anytime. Okay.
Yes, ma'am. You continue.
Yeah. How will you measure the blood pressure? Fast. Normal
The patient should be
right
seated
arm or left, wait. Right arm or left arm?
Ideally, in the first visit, both arms, madam.
Very good. Okay. You have to take it in both arms, and if it is no difference, much difference, then you can start measuring in the right arm, because right arm is comfortable always for us. Okay. Position.
The patient should be in the sitting position, madam, with both arms rested, and the legs should be supported, and she should not be seated with the cross leg position.
Okay.
She should be rested for 5 minutes, madam, and she shouldn't have done any exercise or any intake of tea, coffee prior to the.
And one more.
Tobacco.
No full bladder. Okay.
No full bladder.
That is the important thing. Then you take in both arms, and whichever is good. What about the mean arterial pressure? How will you take mean arterial pressure?
Diastolic blood pressure plus 1/3 of pulse pressure is taken as mean arterial pressure.
So it will take one arm or two arms, or average of four readings
of both arms.
Average. Okay. Normal mean arterial pressure is
75 to 105 is normal, madam.
Up to 85. If it goes more than 105, you think it's a okay. Now we have taken a gestation score. You have taken the mean arterial pressure. You have taken the uterine artery Doppler. You have taken between 11 to 13 weeks, right?
Yes, ma'am.
Okay, can you repeat the uterine artery Doppler? You need to repeat the uterine artery Doppler, or only in the first trimester will it do?
At 22 weeks, we can repeat the uterine artery Doppler.
You have to repeat in the second trimester and third trimester, and the value will be accordingly. It will be around 1.5 or 1 in the third trimester, and it will be 3 in the first trimester. Okay. Then what else? Placental growth factor. What is the normal level?
More than 100 picogram.
So you don't have to worry about the SFLT PLGF as of now. You just do all these things and go to the second trimester. Okay. Next slide, please.
One comment about the recording of blood pressure. Dr. Vijaya has raised that, in pregnancy, sometimes it so happens that while recording the diastolic blood pressure, if you are using a mercury sphygmomanometer, the mercury level goes up to the 0. Then where do you find the diastolic pressure in this patient? Is it a Korotkov 4 or a Korotkov 5? That is the question.
So usually Korotkov 5 sound is taken as diastolic blood pressure, but if it is not heard, then you can take Korotkov 4 sound as diastolic blood pressure.
So that means that if it comes to 0, you have to re-elevate this thing and get it elevated past, say, 120 or something like that, and bring it down and note where the muffling is happening. You have to be all ears. Muffling is not so easy to determine. Okay. So this is very important that whenever the diastolic blood pressure or the sound of the diastolic blood pressure goes down up to 0, you have to re-elevate and then recheck. You have mentioned about the position of the patient, sides of this thing is very, very important. Do you need to take the blood pressure of the lower limbs also, or only upper limbs will do?
Sir, if suspected mean heart disease with so if there is any disparity between both the limbs, then it is ideal to take the BP recordings also from the lower limbs, sir.
Okay. Otherwise, you won't go to the lower limbs. Okay. And the second question is, suppose there is some disparity. Okay. And how, do you change the position or you keep in the same position and then measure?
If there is any disparity between both limbs, sir.
What is the cuff rule about the blood pressure checking? How long or how broad the cuff should be for measuring the blood pressure? Cuff is very important, and we usually use the same cuff for all the patients.
No, sir.
Be it 100 kg patient, be it 60 kg patient. Do you have different cuffs for different patients?
Yes, sir.
You have.
So according to the arm circumference of the patient, we take the cuff size, sir. If it is less than 33 centimeters or more than 30 centimeters. So accordingly, we put the cuff size, and ideally the cuff should encircle 1.5 times the arm, and it should cover 80% of the arm, 2 finger breadth above the cubital fossa, sir, to ideally record a good blood pressure.
Okay. So you have talked about the gestosis score. Did you take care of this mean arterial pressure while computing the gestation score? I mean the gestosis score?
Yes, sir.
That should be included in the calculation. Okay. Now coming to the investigations, I just want opinions from the faculty members. Also, Archana is here, and find whether the students should talk about the investigation. Normally, during examinations, the investigation reports are not available. If you mention some investigation, like you have mentioned here, you have to ensure that the patient has provided this, or rather the records are available, they are given to you. Otherwise, investigation becomes a part of, not a part of your presentation, but it becomes a part of your crossing. Okay, so remember this. All the investigations has to be provided by the system. Yes, doctor. Any other question?
About the family history is important?
Yes, madam.
Previous slide. Family history, how much importance is there in HTP?
Please go to the previous slide. I would like to ask some basic questions.
Basic, yes.
Yes, yes. On the first, no, the first, the second slide. Yes, the second slide. Yes, here you have documented these things. No, not this one. Yeah, the history of the first trimester history. In the first trimester history, you took some points. Yes, this one. Yes. So it was conceived spontaneously. So tell me the importance of each of these points that you have mentioned. What is the importance of this point? Conception spontaneously.
The assisted reproductive techniques has a risk for development of hypertension, madam.
What is a risk?
ART technique.
Yes, you're right. Yes, rightly so. Confirmed by urine pregnancy test in the second month of gestation. So UPT was done, and what is the importance of UPT here?
Madam, if the urine pregnancy test is detected early in her pregnancy, she would have gone to the checkups early, and thereby screening is possible. If any high risk factors are present, then she would be advised aspirin early in her pregnancy, which reduces the risk for further preeclampsias. At least preeclampsia risk.
Anything else other than this? We take this history in all patients, isn't it? When was a UPT done? So we know that the patient is pregnant now. We are seeing her now. So what is the relevance of a positive UPT in the first trimester?
Can others be repeated, please?
अभी क्या तुम्हारे डिलीवरी के बाद क्या होगा? Madam, in her first trimester, if she has done a pregnancy test and the UPT is positive, and then when she comes to the hospital, a baseline dating scan or viable scan will be done, and if it is and confirm the presence of intrauterine gestation. In the case of molar pregnancy, if it is detected,
no. That what I wanted to do, that it is a way to confirm your EDD. Okay, so that is what there are different points in the history by which we will want to reconfirm and corroborate the EDD. Okay, so that is everything. What is her gestation age right now? So this is when she was UPT positive. She was at least 4 weeks pregnant, isn't it? So that is one way of cross-checking, okay, whether her LMP is right or not.
Right.
And folic acid was taken regularly. This perhaps you already know. Drug intake and radiation exposure. Yes, why so?
1 minute, I just want to ask why IVF conceptions are a risk factor for preeclampsia, right?
Yes, madam.
Why?
The role of immune tolerance comes here, madam, because the mother has to combat with the maternal genes, outside maternal genes, and also the fetal genes if it is an IVF conception from the donor ovum.
The high estrogenic environment during conception. Okay. That is a risk factor for
So there is some noise from Dr. Vishy.
I think Dr. Vishy Rawat, can you hear me? I think Dr. Vishy Rawat, can you hear me?
The IT people, can you mute?
I think the host people, can they mute her?
ताकि पे कोई लोड नहीं पड़ रहा है इस तरह से और लैट्रिन से कड़ी तो नहीं हो रही है.
She's not aware that she's, she's not,
Yeah, but I think host can
He
mute.
can be called and asked to stop.
admin, please mute Dr.
Mute
Rishi Rawat.
herself. Can mute. No, she can mute herself. Just call her.
पहले डिलीवरी से पहले जांचें होती हैं वो सब कराई थी.
Just call her if you have any contact number.
Can someone call up Dr. Rishi Rawat? Can someone call up Dr. Rishi Rawat? Is she a faculty?
Any contact number?
Please mute her. Please mute her.
Muted, sir. Muted.
IT coordinator, please mute Dr. Rishi.
Hafiz.
इतना जब वो स्पाइनल लगा ना तब वो कवर बहुत हार्ड होता है. टीचर ने बहुत प्रॉपर स्पेस नहीं बन रही है जैसे कि मुझे लग रहा था कहीं और हाथ डाला बच्चा घूम गया. अब घूमा बच्चे को और जगह कम में बड़ा मुश्किल निकालना. थोड़ा टाइम नॉर्मल से ज्यादा टाइम लगा था उसको निकालने में. तो जैसे ना फिर जल्दी भेजा फिर थोड़ा ट्राई और पर्सन आईपीओ फॉलो का जवाब दे ही नहीं हो पाएगी क्या.
I don't know how is she here. She's not a faculty of this program.
She must have joined through delegate link, I think.
Oh, host, please mute her.
No, this is not delegate. This is a faculty list. How did she get hold of the faculty list? I don't understand.
Yeah, but she's not visible here. Just in the participant list, she's not there.
Anyway, admin, please mute Dr. Rishi Rawat.
Inform Dr. Hafiz. Inform Dr. Hafiz.
Okay, so
anyway, my hello. 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 Hello, hello.
बिना रक्षक तो आप शाम को कर सकते हैं. आप पूरे रात का प्रोग्रेस आप क्या और अब तक
कर दो मैं सकता हूँ वो तो वायरल हो गया.
Dr. Rishi, please mute your audio.
सही बात है.
उसको आप डिले करते चले गए
नहीं अभी मैं आपकी में छोड़ हमने क्या करेंगे रात को. हमने कहा कि 8 बजे 12 बजे डाल दो तो देखा जाएगा तो कुछ होगा. फिर कुछ ऐसा हुआ कि नहीं ऐसा
Dr. Rishi.
हाँ
I just asked Hafiz to
हमने नॉर्म से किया तो नॉर्म से देख ही रहे
just unmute her.
Let the admin please mute her.
Or admin had informed. Who is the admin here?
हो गया कुछ हो गई होगी
We can continue. Sir, we can.
it is difficult, but I would have to continue because the time is a
You
constant.
can continue, sir.
Yeah.
Sir, she
Hello,
is
my
not
question
muting
is-
herself, sir, Dr. Rishi.
Hello.
Please,
Hello.
please.
My question is, they mention aspirin. So, what is the pathophysiology of development of gestational hypertension? And in relation to the pathophysiology, what is the role of aspirin?
The pathophysiology of
The pathophysiology of development of gestational hypertension. And you mentioned to start aspirin. What is the mechanism of action of aspirin?
aspirin reduces the synthesis
First,
of
pathophysiology of development of gestational hypertension. And the role of aspirin.
because of abnormal placentation is the main pathogenesis of gestational hypertension, sir, in which there is
Normal
the
placentation means what?
two steps. abnormal trophoblastic invasion of the spiral arteries, sir, that resulting in more resistant breast flow arteries. So it leads to uteroplacental insufficiency and placental ischemia, which induces an inflammatory reaction. There is a cytokine release and interleukin release that causes endothelial cell dysfunction, resulting in platelet aggregation, activation of the coagulation cascade, and intravascular fluid loss into the interstitial space. And there is an imbalance
in one single word, vasodilation or vasoconstriction.
Yes, sir. Vasodilation increase.
There is imbalance between angiogenic
permeability, sir. There is imbalance between angiogenic and anti-angiogenic factors,
making the vessels go into vasospasm, sir, mostly thereby
That is the
increasing
vasoconstriction.
resistance.
Then what is the aspirin and what is the mechanism of action of aspirin?
Aspirin inhibits the cyclooxygenase enzyme, which reduces the synthesis of thromboxane A2 without affecting the prostacyclin production.
And from which gestation aspirin to be started?
Ideally, it should be started at 11 to 14 weeks, sir, and continue till 36 weeks period of gestation.
But before 16 weeks.
Less than 20 weeks.
And you can continue up to how many weeks of gestation?
36 weeks.
36 weeks. Okay.
When should you take aspirin?
Madam?
When should you take? What time of the day?
Aspirin should be taken ideally at bedtime, madam.
Preferably in the night.
Preferably night.
Okay, go to the next slide. Yeah, what is why we have changed from TT to TD? We were giving tetanus toxide, right? Now we are giving TD. What is TD? What is
We're
TD?
adding diphtheria also to the vaccine. Tetanus plus diphtheria.
Okay. And also Tdap, some private.
That can also be given, madam.
Why we are giving now? Why we have changed suddenly to TD and Tdap? We were giving a very, very happily TT, no? Why?
To prevent neonatal, because to prevent the neonatal tetanus and the complications unto it from that.
That is TT. What about D and Tdap?
Diphtheria and pertussis, they cause more morbidity in the neonates, madam, perinatal morbidity. Immunoglobulins which we give, they can also cross the placenta and thereby confer some immunity to the fetus inside, madam, thereby reducing the perinatal.
We are giving pentavalent after delivery, right? Yes. To the newborn. We are giving pentavalent.
Yes.
Diphtheria, pertussis, tetanus again, no. So this is to prevent the early 6 weeks of diphtheria and pertussis. Okay, pentavalent is given at 6 weeks of neonatal life. So before 6 weeks, the newborn should not get diphtheria or pertussis. That is why now we have changed to TD or Tdap. Okay, okay. Any other screening could have been done in the first trimester apart from PLGF, uterine artery Doppler, any other? We have to be little fast, I think, no, because the time is not there.
Yeah, you have to be a little fast, yes.
PAPA, yeah, PAPA is also another screening test to do it. Okay, okay, go to the next slide. In the third trimester, is there any this thing? Okay, in the cardiovascular system examination, you don't have to say that much. Okay, it is not a heart disease complicated pregnancy. You were telling inspection, palpation, no, all those things are not needed. And CNS is also not needed in pregnancy as such. Okay, so those are the things you could have skipped. Okay, and organomegaly, it is very, very tough in the third trimester. So don't commit to all those things. You said obstetric grips, there is no liver spleen and all. It is very tough in the third trimester. Okay, okay. I think we can go for the discussion, Dr. Ashish sir.
I have one query because you mentioned in third trimester she had blood pressure of 140/90 and she was put on labetalol 100 milligram BD for that. So what is the normal? Normally, when do we start antihypertensive? At what blood pressure? It was just 140/90 and she was started on tablet labetalol.
The repeat recordings of 140/90 in the interval of 4 hours. Then you can start her on.
Pardon?
On 2 occasions, she got recordings of more than 140/90, madam.
So is that the protocol we start antihypertensive?
Antihypertensive should be started once the blood pressure is more than or equal to 140/90 millimeters of mercury, according to ISS HP model.
Yeah.
So which guideline we are following? NICE guidelines is different. ICOG guideline is different. So which guideline are we following?
We are following FOGSI guidelines, madam. We have got 2026 FOGSI guidelines, and
what we are following that.
Earlier, we were starting only if it touches 100. But recent guideline says, even if it goes 140/90, we have to start antihypertensives. That is a new thing that has come. What are the investigations we will do for hypertensive disorders of pregnancy? Fast.
Madam, first I'll start her with urine albumin test, madam. The urine albumin dipstick by dipstick method. So
What is the indicator in the test? That's
proteinuria, madam.
Wait. What is a strip? There is an indicator. No, what does that indicator? You just dip the stick in the urine, right?
No,
and it changes the color. What is that indicator?
Tetrabromophenols.
Blue. Very good. It's a tetrabromophenols blue. Okay. So you will do the dipstick. Then second one is?
Complete blood count is done, madam, to know the anemia.
Urine only you finish fast.
Okay. Any RBCs or any microalbumin.
Other
hypocalciuria.
Spot
protein by creatinine ratio, madam. That is more than 0.3% or 30 milligram per millimole.
You do albumin creatinine. What is the normal value?
More than 8 milligram per.
Okay. Class. And 24 hours urine protein we are not doing nowadays. It's cumbersome. So we have just almost dropped it. Okay. Going to the blood test. Tell me what are the blood tests?
Complete blood count is done in the initial, madam. So we look for anemia and we look for platelet count, madam. Platelet count of less than 1.5 lakhs. So there is thrombocytopenia. If it is if the platelet count is less than 1.5 lakhs, we should also go for peripheral smear and coagulation profiles, madam. So after complete blood count, we see renal function test. So if the creatinine is more than 1.1 milligram per deciliter, so it indicates the preeclampsia or end-organ damage has started. Normally in pregnancy, it should be less than 0.6 or less than 0.8. And we do LFTs. We look for the rise of...
What is important? Is it SGOT or SGPT?
Aspirate transient SGOT is important.
SGPT is more important in AFLP. Okay. Okay, next.
Before you go any further, I just wanted to ask you about one treatment, history that the patient has provided. For the first time when she went to the private hospital, her blood pressure was 130/90 millimeter mercury. And then only she was started with tablet labetalol, 100 milligram twice daily. Now, suppose you are a medical officer after passing, you are posted in that private hospital. Do you do the same thing, or you want to do something else, something extra?
Sir, it is.
And then the patient was released from the OPD, right?
Yes, sir. Sir, since the patient's blood pressure is 130/90 at our OPD, we'll also advise her home BP monitoring. If it is less than 135/80 millimeters of mercury, then it may indicate any white coat hypertension. So, after confirming that the patient's BP recordings were above 135/85 millimeters of mercury even at home, then I'll confirm the case it has gestational hypertension and I'll start the case on labetalol 100 ml.
No, before prescribing labetalol, would you like to have something, or you just give labetalol as it is?
No, sir, I'll
and then release the patient from the OPD. Do you do that?
If she has any history of asthma.
So what is the ideal treatment to be done at this stage? You have found out that the hypertension is there, and she has come for a checkup, antenatal checkup, and then you check her blood pressure 130/90. You start. You give labetalol 100 milligram twice daily, and then you let her go.
You admit her for daycare.
4 hours apart blood pressure.
So that was not done here, right? That was not done here. And the result is obvious after 2 weeks. When she came back, her blood pressure was 150/100 millimeter mercury, and also she developed proteinuria. Isn't it? Okay, so you should have admitted for a daycare, this thing, in a treatment, a daycare.
She was admitted. So
and
even
then,
in the exam, you should say, even in one rise of BP, admit, observe, and take monitoring and do the basic investigation. And if she is very stable, then you can send her and do with the home BP monitoring and frequent AN checkups. Okay. As an exam PGs, you have to tell, I will admit, because 130, 90, 140, 90, you have to admit the patient. The other one is
Because of not admission, she developed into preeclampsia. There is, I think, that periphery hospital just 2 hours away from the Visakhapatnam. They are not doing proper investigations and management of gestational hypertension.
When will you be repeating the urine album? Will you do it every time, every day, like that?
The urine albumin has already been found positive. There is no role of since repeating urine albumin, and it does not have prognostication role.
Positive means
more than or equal to 2+1.
2+, yes. Till it is 2+, you can do it period. Once it is 2+, it is there and it is a damage to the glomerulus, and there is no point in repeating the urine album. Okay, come on. Next, blood investigation. Urea, okay. SGOT, SGPT, okay. Then
SGPT rise and LDH
coagulation profile.
But as per the guideline, they say coagulation profile
Not
only when platelets started declining. Okay. What about fundus examination?
Fundoscopy should also be done, madam, to rule out any acute changes or chronic retinopathy changes. So if it is a case of chronic retinopathy, then we will be seeing arteriolar narrowing or AV nicking or any cortical spots or
chronic hypertension. No, this is Pushner's retinopathy and Amaurosis fugax. Also temporary, which is easily reversible in preeclampsia. Okay, coming to the drugs, I think we can go with the drugs, sir. Only two, sir. Steroids and Maxel, sir. Then you can take over. When will you give steroids?
Yes. From 24 weeks to 34 weeks, we'll give steroids for improving fetal maturity.
Okay. Is there any time cutoff where you will deliver the baby once you put the on steroid?
If we are anticipating the delivery within the coming 7 days, then we'll start
within a week. Then only there will be a maximum effect. What about the rescue dose of steroid? Is there a role of rescue dose? You will repeat the steroids again?
So since the last dose of corticosteroid 7 days have happened, and now the patient is coming with a preterm labor, or she has to be delivered now with preeclampsia with severe features, then the role of rescue dose of steroid is there.
Still exists. What about magnesium sulfate as a neuroprotective? I'm not asking about the suspend regimen. Now I'm just staying with the neuroprotective effect. Once you have started the magnesium sulfate, when should you deliver the baby?
Within 24 hours.
The maximum protection.
Maximum protection. 24 hours.
So you have to deliver within 24 hours. Okay. Only in that situation you can. So suppose the patient did not deliver. Okay. You have completed the max sulfur. Can you repeat the neuroprotective max sulfur?
Yes, ma'am. If it is after 4 weeks, we can repeat one.
Super. Very good. Okay. Okay. You can go on, madam. Antihypertensives. Can we go to antihypertensives? So
now, what investigation is remaining?
Yes, sir. You can ask.
An obstetric Doppler, because we have to take, because she is at 37 weeks with preeclampsia.
Yes,
she completed her 37 weeks. Then because we have to plan her delivery and manage, because beyond 37 weeks, we may not continue. So which investigations, which finding of obstetric Doppler, we have to act immediately?
So if it is a case of
cerebroplacental ratio is the marker in the.
We have done sonography and obstetric Doppler in patients with preeclampsia. Which finding of flow we have to act immediately?
Reversed arterial flow or absent endostic flow in umbilical arteries.
Okay, so come to the treatment now. We have a little time left now. We have only 5 minutes. So, Shohini, do you have any questions on the management? Or
So you have started the patient on labetalol, 100 milligrams twice daily.
Yeah.
So what do you expect the blood pressure to be? What should be your target blood pressure?
It should be less than 135 by 85 millimeters mercury, as in the case of gestational hypertension.
135 by 85. What guideline is that?
FOGSI Gestasis Guideline 2026.
FOGSI is saying that. So why not less than that? Why not 120, 70?
Fetal perfusion is reduced if it is very less, madam. So we keep it the baseline as 135 by 85 to maintain the uterine.
Use the
Yes.
BP promptly but slowly, ma'am.
Okay,
Yes, you
this
are right.
patient, this
Okay,
patient,
so
she
here, so you see
experienced,
that the blood pressure is yes, sir.
she
So you see that
experienced two
It is
different
there, Lagde.
stages. She was started with the oral, and then
Yes.
she was switched over to the intravenous. What was the reason behind it?
Non-compliance. Sir,
When do you give IV labetalol?
if it is a case of hypertensive emergency,
The
like
BP is more than 160 by 110 millimeters of mercury, we'll go for parenteral treatment. Or if she is in labor, the oral cannot be absorbed well. In that case also, we can go for IV preparation.
What is an hypertensive emergency, and what is an hypertensive urgency?
hypertensive emergency is such a condition where the BPs are more than 160 by 110 millimeters of mercury and they are not even being controlled with the medication. And the risks of intracranial hemorrhage or other complications with the hypertension are more in such conditions like in eclampsia or past deterioration to the health or acute renal injury or liver injuries, pulmonary edema. So in that condition, we need to deliver the case as early as possible. And the mode of management also differs depending upon if it is an urgency or emergency. So,
Now, what was urgency? Didn't define urgency.
urgency is BP more than 180 by 120 millimeters of mercury, sir. And
see, basically, the difference is that there is involvement of other organs and the appearance is signs of preeclampsia, isn't it? That means it is more extensive. So you have to, bring the BP down quickly. And so that is the reason why you switch over to the intravenous regime. Now, I was wondering why she was given just one dose of 20 milligram of labetalol, and then nothing is mentioned about that. What was the follow-up of that dose? Was it repeated in the same dose, or was it doubled? What was the ultimate blood pressure level like? All these things are required to be mentioned here.
Yes.
Show us the slide, that slide, when she was given 20 milligram of labetalol IV.
Haven't mentioned the repeat in the reports. They have just mentioned single dose of
See, the blood pressure level hasn't crossed 110 here. The diastolic has not crossed 110, but you have given intravenous this thing, okay? Labetalol, 20 milligram IV, and injection magnesium sulfate is okay. What happened to the follow-up of this 20 milligram IV?
What did you do?
Admission, her repeat BP was 150 by 90.
So you stopped the labetalol, right?
No, madam, we have given labetalol 20 mg IV. Along with that, we have started her on magnesium sulfate maintenance dose, madam. As she is also having headache as it is an imminent.
We are not talking about magnesium sulfate. Tell us about what happened to the labetalol dosage 20 milligram IV. What follow-up was done after that?
Did you repeat after 20 minutes, and what happened? That's what Sarah is asking.
How do you follow up a patient who is receiving IV labetalol? That is what Sarah is asking.
The patient must be rechecked with the BP monitored after 15 to 20 minutes, madam. So since
what do you expect
measured,
then?
but at the BP
150 by 100 mm of mercury.
I can't hear you.
We gave her oral labetalol and kept her on BP monitoring as her BPs are within normal range.
So you have to write that because this treatment is happening in your hospital. There is no record of what happened after administering IV, whether you continued with the IV therapy or you stopped the IV therapy and shifted to the oral therapy. What was the blood pressure level like? She should be needing constant monitoring, isn't it? It's very important, right?
So once you have started an oral labetalol, when will you start the second antihypertensive? What is the cutoff?
Madam, if the dose has reached, if it is oral 1200 milligrams, half of the maximum dose is reached, then we'll start with the second antihypertensive therapy if it is an oral regimen, madam.
After 600, how much you are telling? Half
1200, madam. The maximum is 2400 mg, madam, per day. And if she has reached the half dose, that is 1200 milligrams, then we add the second antihypertensive, madam.
Okay.
2400 is the toxic dose. We never go to 2400. We go up to 1200. And if it is not controlled by that, then we add a second antihypertensive. What is the second antihypertensive? What is the dose and route of administration?
20 mg per oral is given, sir. PD or TID. This is a sustained release. Maximum dose we can give up to 120 mg.
In hypertensive crisis, can we give any other form of nifedipine apart from IV level?
Available, madam.
Then there's a IV preparation, madam, which is more water soluble and have relatively rapid action.
Immediate release nifedipine is also available. Okay, that also you can give. So, okay, having started Maxself, are you planning to terminate? Is
Yes,
it a
madam.
decision that you have to terminate?
Madam?
How will you terminate this patient?
Madam.
No delivery.
Sir, since this is a
37 weeks, blood
eclampsia
pressure
with
controlled, everything done. You want to continue for another 1 week, or you want
No,
to induce her, or what? You want to go for direct C-section? What is in your mind?
Sir, we want to go, we will first counsel the patient
Bishop
and
is
after
poor.
take
Bishop is poor, 3/13.
Yes, sir. Sir, now we have started the patient on magnesium sulfate, and now after coming to King George Hospital, her BPs were under normal level. That is, she has been, her BP is 140/90. So we have started induction, sir. Her Bishop's is 3/.
Induction or pre-induction cervical ripening. What is the difference between induction and pre-induction cervical ripening? If Bishop is poor, you can't directly go for induction.
Cervical
Yes,
ripening
sir.
with
the prostaglandin,
cervical
sorry, prostaglandin gel can be tried. And after that,
How many cervi primes?
sir, in our institute, we are following
What
3
is, what is
doses
the
of
what is the
cerviprime.
generic name of cervi prime?
Dinoproston.
You know, it is a intracervical or in the posterior fornix?
Intracervical, sir.
In how many doses and how many
3
hours?
doses, 8 hours, sir.
8 hours.
6 to 8 hours. 8 hours, sir.
Then?
Okay, she is having 36 weeks at the moment, isn't it? When do you plan to start? When do you plan?
7 weeks at this moment.
Then after this pre-induction cervical ripening, what next?
Sir, I'll be monitoring the mother, both mother and the fetus also. The mother is monitored with her BP, pulse rate, saturations, and her urine output, since I'm also keeping her on magnesium sulfate. And I'll be
That
monitoring.
we are doing. But now we have to proceed further for her delivery.
So I'll be plotting partogram, sir. If it is progressing smoothly, then I'll continue with the normal labor. If any time the BPs are high, or if the patient is going into eclampsia, or if any abruption develops, or if any complication for that matter develops, I'll take the case to cesarean section. Before that, I'll be asking my anesthetist to come
Cervical
and perform a
dilation, you will go for artificial rupture of membrane.
more than 4 centimeters, sir. In the active labor, sir. In the active labor, I'll be doing an artificial rupture of membranes, and then I will be augmenting the case with oxytocin.
Oh, augmentation with oxytocin is after how many minutes of ARM? Immediately or after some minutes or hours?
30 minutes, sir. After
Why?
30.
Why? Because what ARM does?
So it will release prostaglandins into the local region, and it also induces, it augments the labor.
Okay.
And after
So you have decided for an aggressive induction of labor with the help of cerviprime gel, you said, isn't it? Okay.
Yes,
Now, how many doses can you maximally give to her? Suppose this thing is not working, and you said you will repeat after 6 hours. And how many such doses will you give her?
3 doses, sir, maximum.
3 doses you follow. Okay. Okay. And how do you do the fetal monitoring? By which gadget?
By continuous CTG monitoring and
Non-stress test.
Okay. So continuous CTG monitoring is available. So you are doing that. Okay. Now, and you said that in the in the event of any fetal distress, you'll take her for immediate cesarean section. What are the indications or the findings in CTG that will prompt her for a prompt cesarean section?
prolonged deceleration more than 10 minutes, a prolonged deceleration or late decelerations, bradycardia.
Lasting for more than 10. If there are uncontrolled
Sinusoids. B2B variability or any sinusoidal patterns.
Okay. Now, what are the indications for elective cesarean section in this case? Suppose you need to screen out the patient who need elective cesarean section in this case.
Elective cesarean section can be done in obstetric indications, like if the patient is also having any placenta previa, or if the patient has contracted pelvis or cephalopelvic disproportions.
Tell only the indication in this case, not obstetric indication.
Elective.
Okay. Uncontrolled severe hypertension. And Doppler changes. Doppler.
Health syndrome, imminent signs, development of any eclampsia syndromes, any worsening of the lab parameters. Then we'll go to this section.
Archana, you are there. You want to ask questions, or you want to keep it reserved for the quiz?
Yeah, I'm preparing for the quiz actually.
Okay, I know. I can understand that. Okay, now Shohini, do you have any other question? I will wind up the case now.
Yeah.
Dr. Tambe, do you have anything else to ask, sir? And Dr. Vijaya. We are
Sir,
going
the
to the final round.
postmortem is important, sir.
Yeah, very important. Very important.
Have to monitor the blood pressure, and if the BP is still uncontrolled, we have to definitely take the physician. And because the long-term risk for the patient and as well as the fetus, the newborn also can develop because of the hypertension in the mother, cardiac remodeling and myocardial hypertrophy, lots and lots of dangerous effects for the newborn.
Yes.
So both have to be very much followed. That is very important. And also the recurrence is very important. So you have to tell the next pregnancy, they have to be really careful. And also you should tell the prolonged breastfeeding will definitely reduce the blood pressure. The recent trials have proved that. And apart from that, all the trials, the parrot trial, the chip trial, the chap trial, and the hipitad, everything you should read. Okay, ma, we are not telling all those things because it is given in the net very well. Okay,
Correct.
just
Correct.
check on that. And otherwise, they are too good, sir. They did answer very well. And how does magnesium sulfate act? I am sure you must be
Hold
knowing.
it, Dr. Vijay. I'd like to ask another question. What antihypertensive would you like to use in a postnatal period? Would you like to change it or continue the same level?
Very good.
Same
Pardon?
drug with which they got
Same will
control.
continue.
We can continue the same drug in the postnatal
You
period.
can also change, no? Amlodipine and
Also other
Enalapril is a good choice.
Enalapril,
Yes,
yes.
Enalapril is written in the RCOG guideline. So we can use that.
and also apart from prevention, aspirin, you can give calcium at a higher dose. Vitamin D also coming into a long way, and they are also going into for statins and prazosines. All those things are recently coming
A
up.
lot of things, yes, we couldn't discuss because of limited span of time. Dr. Vijay, thank you very much.
Thank you so much, sir. Thank
we
you,
couldn't
sir.
discuss SFLT1, we couldn't discuss many things, but we have more or less tried to, utilize the time and see how much they have done. Yes, Dr. Sheila Mane is here. Sheila, do you have any
Hello.
questions?
Good afternoon.
Hello, I was listening since 15 minutes, just came out of the flight.
Okay.
Nice discussion. Yeah. Okay. Hypertensive disorders, there is so much to discuss. I was hearing.
So you give us some questions from that height, 36,000 feet.
No, I just wanted to tell that through ICOG, I'm also starting a study on FIGO pregnancy passport, where all the high-risk pregnancy we should be followed. Okay. So not only this, all the high-risk pregnancies. So that is another study which we are taking through ICOG. So hypertension, diabetes, cardiovascular, thyroid disease, everything. I mean, and I prepared a card also, and that will help us to methodically follow all the patients.
Correct.
So how we are keeping the record of all the high-risk pregnancies according to Government of India. So postnatally also, because, for the next pregnancy, again, the preconceptional care, and as you rightly said, the incidence of cardiovascular disorders is higher in them. So I think we also have to, with the changing trends, we have to start telling our mothers or women that take care of your own health. Yeah. Thank you.
So this
Thank you all.
concerted effort from the ICOG chairman, you just heard, she's always constantly thinking about the mothers.
Yes.
And also, even if she's flying in a flight, also she's thinking about the mothers. So that's a very big thing. And it's no wonder that our maternal mortality has come down a bit now and is going to be achievable of the SDG level, that is less than 70 very soon. Happy flight to you, Dr. Sheila. And
thank you.
I'd like to request everyone, every faculty member, to give them an ovation on these two beautiful girls, Veda and two students. They have done exceptionally well, and I think that only thing that they need to study is the trials, as Dr. Vijaya said, the chip trial, the Hypetet 1, Hypetet 2 trial, etc.
Yes.
Everything you must understand, because we couldn't discuss them in the case discussion today. All the best for the future, and thank you.
They are daring to it, sir. I should not have disclosed, but.
And all the best to Sheila Mane.
Thank
all
you,
the
Dr.
wonderful
Sheila.
things.
Thank you, Dr. Sheila, and thank you, Dr. Ashish and Vijaya and Archana and all. Thank you for appreciating our PGs, their hard work. Even they know the trials also, madam. The time shortage is there. Thank you so much for encouraging them.
Thank you
you
so
very
much.
much.
Thank you.
Thank you very
And
much.
I
Thank
will
you.
take 2 more
And
minutes.
all my best wishes for those two young PGTs. They have done really well, and I wish them all success in the ensuing
Thank you,
exam.
madam.
Yes,
Thank
Sheila,
you.
your
Good
two minutes start
presentation
now.
and very good preparation.
Yeah. One more, 2 more.
Andhra Medical College.
Thank you, sir.
From Andhra Medical College.
And
This is the
Veda
second time our PGs are presenting, sir. We'll take the opportunity again.
Correct.
Thank you,
We
sir.
have to book the
I
next
just
session.
want to, Ashish, to tell them everybody about again the placenta accreta spectrum registry.
Yes. I've
Okay,
already started
so
them.
because all
We did,
teaching
madam.
staff here. Yes, Dr. Saudamani, I heard that, Saumini, and I'm really happy.
Thank
So
you, ma'am.
whosoever gets the case, start uploading. Website link is also available on the website.
Yes.
And this group also I will share. So we have to spread it more and more. So
Even
Ashish, in Bengal
Dr.
also.
Deepa, Dr. Deepa has started another performer also to roll it, ma'am.
No, but we have a registry. So if you can
Yes, ma'am.
upload your cases there,
Yes,
it will be good. Okay, everybody in your own state, medical colleges. Thank you. I just take the opportunity to spread the word so that we get a great data. Okay. Yeah.
Thank you, madam.
Everyone. Ashish sir, thank you.
Thank you so much.
Thank you. Thank you, Celia madam. Thank you, everyone.
Thank you. Have a nice day.
My future endeavor. Thank you very much.
Thank you, sir.
To all of you for your kind support. Hafizur, it's over to you now. Would like to start the next session because we are in time now. Hafizur, are you there?
Next is specimens, no?
Yeah, specimen. Dr. Deepanita Banerjee is going to deal with a specimen, Vivavosi, and it's an oncology specimen. So I invite Dr. Deepanita Banerjee. She's here. Deepanita, are you ready with you are going to do it in the slides?
Yes, sir.
Okay.
That will be on the slides.
So you can start now.
Yeah, thank you so much. Thank you, ICOG. Thank you, Hafizul, for giving me this opportunity. So let me start sharing my screen.
Yes.
I hope my slides are visible now.
Yes, it is visible and you are audible. You may start now.
Tackling gynaecology specimens with FLAIR. FLAIR, I don't know FLAIR, but you have to tackle the specimens. All the students, you have to tackle the specimens with confidence, smartly, with knowledge, and with elegance. That is how you are going to tackle the specimen. So this would be in next 30 minutes today, I would be discussing 2 specimens. One is of a cervix and another is for ovarian tumor. So let's start with the specimen 1. So the first question, if you are mostly what you will get a mounted specimen formalin fixed, which is there, which will be showing you the and will is the specimen. So this is describe the specimen would be your first question. So how are you going to describe the specimen? So this is a specimen of radical hysterectomy containing uterus with cervix, with bilateral tubes and ovaries, with vagina, parametrium and paracolpium. So students, remember, if it is a mounted formalin fixed specimen, you have to add that it is a mounted formalin fixed specimen, which you will get in the exam. So the next question would be like, if after once you describe the specimen, the next question would be, what is your diagnosis? looking at the specimen, what would be your diagnosis? So your answer would be very clear, very concise, and don't try invite questions which you know to the examiners and answer your questions to the examiners in a line that they will ask you more questions which you know. So carcinoma cervix stage 1A, 2 or 2A1. So you may continue with this, or you may say that it is a specimen of carcinoma cervix. So the next question would be, depending on the knowing the stage, knowing the how much you know, you can add to the stage 1A2, 2A1 without, probably with or without LVSI. Probably you can add that what is the questions may come like what is 2A1, what is 2A2, what will you do with the 1B? Well, so 1A, 1B1, 1B2, 1B3, these questions will follow. The next question may come as, how will you diagnose a case of carcinoma cervix? So to start with, you will answer the most common history is either white discharge, postcoital bleeding, postmenopausal bleeding, irregular bleeding per vaginum, foul smelling discharge per vaginum, low back pain radiating to lower limbs. If it's a case of advanced stage disease, even the patients sometimes may present with acute renal failure as well. So you have to answer starting from the history, then the clinic. So first comes a patient who comes to your clinic with these symptoms. You have to do the staging by a per speculum examination, looking at the per vaginal examination and per rectal examination. Always remember, for this interpretation of specimen, for the interpretation of the staging of CS cervix is always clinico-radio-pathological. So clinical staging does not, after 2018, FIGO stage come into the place. The importance of imaging has gone up more and more up, and it depends and influences the stage. But clinical examination is always of paramount importance in assessing and doing your homework properly for further management of the carcinoma cervix. So then what you will do, the question examiner may ask, how are you going to do a biopsy? So in that case, you have to tell the examiner that you will do a per speculum examination after you do a proper per abdominal, the general survey, the node lymphadenopathy, the edema if there, the anemia you have to look. Then first, after doing a per speculum, per vaginal and per rectal examination, then you will go for a cervical biopsy. So cervical on clinical staging, you have to look for the vaginal involvement as well, and always the parametrial involvement is best assessed through per rectal examination, which is of utmost importance in assessing the parametrium and as well as rectal mucosa. Then the cervical biopsy, then what will be your further workups? Workups will be on ultrasound, workups will be on MRI pelvis, the CT scan, PET CT plus minus, cystoscopy and sigmoidoscopy depending on the stage or clinical finding. So the first line of management would be CT, chest, abdomen and pelvis. And if you want to early stage disease, you will go for MRI pelvis to see the size of the tumor, the stromal breach if present or not, and assess the parametrium as well. Then after the imaging, all the imaging and pathology reports, the biopsy may come as, what are the types of biopsy? The squamous cell or adenocarcinoma. The final staging, after all the imaging and pathology reports are available, you will be able to see assess the stage of the tumor. So the next question would be, what will be the stage of this? Do you think that what would be her MRI finding or CT scan finding for this specimen, which I have I have shown you? So the stage would depend on the MRI and CT scan finding on lymph node visible or not. If it is visible, if the pelvic lymph nodes or para-aortic lymph nodes are visible, you have to see the size of the lymph nodes. whether it is more than 1 centimeter or less than 1 centimeter. If it is subcentimetric, you may see that you may assess and ask the patient to, after the follow-up, the assessment of the cases, and doing giving a course of antibiotic, may call the patient after a week. More or less the workup is done, and assess again to see whether the subcentimetric lymph nodes were reactive or not, or if you have any suspicion, it is better to go for PET CT scan. So the question would be, what is the FIGO staging of cervical cancer? The staging, I'm not going into the detail, because the imaging does have a big in assessment and stage the disease, because the specimen which I showed you before, it is up to stage 1A, 2A1 we can operate. So beyond that, 2A2 is considered, though the parametrium and upper vagina, parametrium is free and the upper vagina is just involved, but the bulk of disease is more, the size of the tumor is more than 4 centimeter. So those, what are the bulky disease? 1B3 and 2, even if under those are not operable, where the adjuvant treatment is more or less mandatory for these cases. This is the reason why we don't operate on 1B3 and 2A2. Beyond that, the staging does influence the imaging does influence the staging for the any lymph node positive comes under stage 3. So stage 3, if in 3C, if it is pelvic node involved, so the examiner may ask that if a radiological imaging you see obturator node or a pelvic node is positive, will you operate? So your question will be straightforward, no, because the patient will inevitably receive chemotherapy and it is staged as the locally advanced CA cervix, stage 3C1. So there is no question of operating the patient. You will straight away send the patient for radiation therapy. The question would be that what are the indications? So looking at the specimen, the examiner may ask that what are the indications of radical hysterectomy and cervical cancer? So stage 1A2 with LVSI, stage 1B1 with LVSI, stage 1B2, 2A1. These are the stage of carcinoma cervix where you will offer the patient radical hysterectomy and not any conservative surgery, even if the patient is desirous of fertility. So you may get this type of specimen as well. Looking at this, if the examiner asks that if a mounted specimen, which there are some fibrofatty tissue which has also been formalin fixed, examiner may ask that what are these, or any additional procedure has been done along with the radical hysterectomy specimen. So yes, your answer would be yes. What are those small tiny boxes which I'm showing you right now are the pelvic lymphadenectomy. So in cervical cancer, you have to do the pelvic, you have to take out the bilateral pelvic lymph nodes. In radical hysterectomy, or you have to address the pelvic lymph nodes. And in those above stages, if it is with LVSI positive, you have to see the lymph nodes as well, either through sentinel lymph node biopsy or through pelvic lymphadenectomy. Now the examiner may, next question would be that what are the different types of hysterectomy? So I'm not going into the detail. There are the Piver-Rutledge classification, the Kerr-Lomoro classification, what are the indications, what are the simple extrafacial, the modified radical and radical hysterectomy, where the clamp of the lateral parametrial clamp is above midway or towards the the sacral region. That depends on the uterosacral ligament divided near sacral origin. Clamping depends the type, varies with the type. So type 2 is less radical, type 3 is more radical. Now the type Kerr-Lomoro classification has included the nerve sparing. That would be another may invite another question, that what would be the nerve sparing hysterectomy? It is Kerr-Lomoro classification C1 and C2. C is nerve sparing hysterectomy. Why are we more concerned about the nerve? Because in pelvic, there are chain of sympathetic and parasympathetic nerve plexus which goes through the parametrium, and you have to address, or you have to like spare the nerves more and more whenever is possible to avoid any bladder and bowel dysfunction. So the examiner may ask that what are the radical hysterectomy types? What are the radical hysterectomy types? This is an overview of what are the route of surgery. It may be abdominal, it may be vaginal, it may be minimally invasive surgery through laparoscopic or robotic. The incision can be low transverse, incision can be midline vertical. Low transverse dechernes incision, which is the muscle cutting incision. At the origin of rectus abdominis, you cut the muscle and then bind the inferior epigastric region, inferior epigastric vessels, and address the nodes through extraperitoneal approach. And if the any enlarged node or suspicious node you see, you send the nodes for frozen biopsy, and if it's positive, then you don't have to open the peritoneum and you can abandon the surgery straight away. So that is the benefit of doing an extraperitoneal lymphadenectomy versus transperitoneal lymphadenectomy, because the recovery is much more faster. The steps can be, there is no fixed step that you have to perform radical hyst first, then lymphadenectomy. You may go through lymphadenectomy to radical hysterectomy. So this may question, the examiner may ask that whether you have to address the lymph node first or the rad hyst first. So there is no uniform opinion. You may or may not address lymph nodes first. But it is always preferable to address the lymph nodes first, because if it comes as positive or if there is any suspicion, you have to, or recommended to abandon the surgery straight away, because the patient, if the lymph node, as I mentioned before, if it is lymph node positive, the stage immediately becomes stage 3C. So the patient inevitably will receive radiation therapy, and both radiation therapy and surgical therapy in early stage ovarian cancer are equal survival benefit, and it is always better to avoid dual mode of therapy for cervical cancer to avoid the side effects of both the procedures. So the examiner may ask, okay, fine, you are doing the radical hysterectomy, so what are the pelvic spaces? So there are mostly the paravesical spaces, pararectal spaces, which are what are the boundaries. Now there are Latsko's pararectal space, there is Okabayashi's pararectal space. These all come into this. I am sure that you guys know, and you have read it multiple times, that there is Yabuki space. All this space division is to avoid any damage or injury to the nerves, which may affect bladder and bowel and sexual function. So this is according to these spaces. You have to read it by heart. Now, all of you know the Piver-Rutledge, all of you know the Koldo-Moro classification, but what is the new anatomic classification system? So how will you address the new anatomic classification? The Dr. Mualem in 2021 came up with a three-dimensional concept of parametrium and paracolpium, and a comprehensive description of the anatomy of parametrium, paracolpium, and pelvic autonomic nerve system. So this is the type he has described, type 1, 2, 3, and 4, where he has addressed the paracolpium. So it is not only the parametrium. For radical hysterectomy, you have to take the paracolpium tissue as well. So the examiner may ask that what are the preoperative preparation? Don't forget, you are looking at a specimen mounted of radical hysterectomies. The examiner may ask, which is what preoperative preparation will you do for this surgery? So your question would be, first is consent, then the blood reserve, then bowel preparation. If you go by the ERAS guideline, then it is enhanced recovery after surgery guideline. Then it is not very much like recommended hard and core, but if it is if there is extensive pelvic adhesions are anticipated, bowel preparation should be there. So perioperative antibiotic immediate within an hour of incision, before at least an hour of incision, then the parts prepare, the NPO for 6 hours for solids and 2 hours for clear liquids. All the students are requested to go through ERAS guideline on preparation for the preoperative, intraoperative and postoperative preparation for all cancer cases. So the VTE prophylaxis, venous thromboembolism, is common in gynec oncology. So injection low molecular weight heparin at least 12 hours prior to surgery is recommended. Now the question would be that what will you explain in the consent? So counseling regarding loss of fertility, need for hormone replacement therapy or menopausal hormone therapy if the patient is young, because CS cervix is rare malignancies where you can offer menopausal hormone therapy in in young patients. This is very much important that you have to explain that the procedure may be aborted if metastatic or pelvic tumor extension is found, because the radiation planning becomes difficult if the uterus has been removed. So that is one of the reasons why dual modality should preferably be avoided for cervical cancer cases. So if any doubt that patient may land up in radiotherapy after surgery, even if it is early stage, so it is better to abandon or control yourself from doing a radical hysterectomy and send the patient to radiation oncologist for radiotherapy. So complication due to anesthesia, the risk of acute blood loss, need for transfusion, prolonged ICU stay, post-op bowel bladder dysfunction due to denervation. If you are doing a type C2 radical hysterectomy, then the risk of symptomatic lymphocyst formation, because it is a common complication after surgery, after extensive lymphadenectomy. And then the intraoperative organ injury like bladder injury, like ureteric injury is very common. Then risk of ureterovaginal fistula, vaginal fistula, of venous thromboembolism, prolonged ICU stay, everything has to be very well explained in the consent, because you are dealing with a disease where there is a chance of inoperability, there is chance of loss of fertility, permanent loss of fertility, and there are various intra-op and post-op complications as well. And patient may require adjuvant treatment, that also to be explained in your consent. Now the question would be that what are the steps of radical hysterectomy? That I am these are the steps where you will evaluate the abdomen. Incision may be low transverse, incision may be midline vertical. The preparation should be aseptic way. If you are doing a sentinel lymph node, then you have to do it prior to address the lymph node and within maintaining the sentinel lymph node protocol. So how will you manage the post-operatively? The Foley's catheterization usually is preferably kept up to 3 days. There is no hard and fast rule that you have to keep the Foley's catheter till 2 weeks or 3 weeks post-surgery. So if it is, that is the beauty of doing a type C1 radical hysterectomy. You may remove the catheter next day itself. The post-op venous thromboembolism prophylaxis with anticoagulant treatment, at least during the hospital stay, injectable low molecular weight heparin, and when the patient is being discharged from the hospital, the oral anticoagulants are also prescribed up to 28 days post-surgery. Early ambulation is always advised, early oral feed, wound care management, maintaining asepsis and maintaining the stitch hygiene is of utmost importance in preventing post-operative infection. Now the question, looking at the specimen again, I'm also sometimes forgetting that what are the complications of surgery, what may be the complications, that acute blood loss, the febrile motility, morbidity, the postoperative bladder bowel dysfunction, lymphocyst formation. All gynae cancer cases may develop a venous thromboembolism anytime during or intra or post-operative period. So you have to explain that in detail. That then in subacute condition, there is patient you have removed the catheter, you are confident enough, you have removed the catheter next day, but the patient has developed urinary retention. So then in that case, it is always preferable to keep the catheter for at least 7 days and then ask the patient to discharge her at the earliest if possible from the hospital, and then ask the patient to come to OPD, maybe preferably with a urinary CS report. The chronic and including ureteral strictures are also there. So intrapelvic injuries can lead to impairment of urination, defecation, and sexual function, and consequent deterioration of the postoperative quality of life. Now the question would be that you have you have taken out a beautiful operative specimen. You are very happy that all the parametrium, paracolpium, everything has come properly with upper 1 to 2 centimeter of vaginal cuff, and tumor is well away from vaginal margin, but the final report comes as the margin is positive or our lymph node is positive, because always remember the histopathology is the gold standard. So what factors decide the need of adjuvant therapy? So what is the risk Peters criteria? That there are 3 P's. One is positive margin, positive lymph node, or positive parametrium. So these are the 3 P's. Any 1 out of 3, if is positive, you have to add chemotherapy with the adjuvant radiotherapy. So 3 P's for Peters criteria. Any 1 out of 3 is positive, you have to add chemotherapy, mostly use cisplatin. The intermediate risk factors is Sedley's criteria, where 2 out of 3, if it comes as positive, you have to add adjuvant radiotherapy, and you may skip adjuvant chemotherapy. You may not. You have to, like, it is radiotherapy. What are the criteria? Lymphovascular space invasion, deep stromal invasion, and tumor size more than 4 centimeter. So these are the 3 criteria where any 2 out of 3, according to Sedley's criteria, is positive, you have to give adjuvant radiation therapy. If 1 out of 3 of the Peters criteria comes as positive, you have to add chemotherapy as well into that adjuvant radiation therapy protocol. All other patients are low risk and no therapy is required. So now the examiner may ask that what is the other management option for early stage cancer cervix? As I said before, concurrent chemoradiation, that is cisplatin adding to the radiation dosage is good enough and equally beneficial for the oncological outcome of the patient in early stage CS cervix. So, but what are the advantages why you have performed a surgery for precise post-operative staging is available through histopathological findings. There are tumors which may be radioresistant, and which you can primarily removing the tumor itself is good. They're possible to conserve ovarian function in young patients, mostly suffering from squamous cell carcinoma cervix, and where the metastasis to ovary is less than 1%. And it also avoids the rare late complications of radiation therapy like sigmoiditis, rectal proctitis, the vaginal complaint, the fistulas, the strictures, so these are the skin toxicities, and late complication like anemia or bone marrow suppression is also can be avoided by the radiation therapy. But the preservation of ovarian and sexual makes a preferred in women. Now the examiner may ask you that can you do a conservative surgery for these cases? So yes, your answer would be yes, that uterus preserving, uterus not preserved. So what are the uterus preserving cancer surgeries? Where for the CS cervix cases, cold knife conization, simple trachelectomy, and radical trachelectomy. But what are the scenarios where the uterus is not preserved and you can perform a type A hysterectomy, simple extrafacial? So these are the stage 1A no LVSI, and these are the trials: conserve trial, shape trial. Conserve is there is no extra E at last, so shape trial and laser trial. Learn this conserve and shape trial by heart, because you know these are the very, very important trials which has changed the scenario of managing the early stage CS cervix cases. So now immediately you have invited questions, and you have read it well. So what are the indications of fertility sparing surgery? So stage 1A1 where no LVSI, stage 1A2 where you have to address a pelvic lymphadenectomy, 1B1 is without LVSI you may consider doing a early stage conservative. So conservative surgery means always not, it is not the uterus can be kept inside. Conservative surgery means there is no need of doing a radical hysterectomy, like removing the ureters from the side, taking the whole parametrium, paracolpium. So conservative surgery can be uterus preserving, conservative surgery can be uterus non-preserving. So how to follow up after fertility sparing surgery? Usually if it is fertility sparing surgery has been done, you have to follow up through pap smears, then 6 monthly for next 3 years. And then otherwise, if a patient who has undergone a radical hysterectomy, there is very little role, and moreover, if he has received radiation therapy, there is very little role of doing a cytology from the vault, because anyways the cells are become distorted through after radiation therapy, and even if it comes positive, there is very limited option, or it implicates situation in managing the case. So always for radical hysterectomized patient, when the patient comes for follow-up, you have to follow the patient up with clinical examination and imaging whenever is indicated. Now the question would be that what is sentinel lymph node biopsy? Sentinel lymph node is the first to receive drainage, primarily applicable in early stage disease. Where lymph node status may influence further treatment. This is the sensitivity specificity. The procedure of sentinel lymph node biopsy, it is maybe 3 and 9 o'clock position. Nodes are identified by usually mostly the ICG. So what are the role of sentinel lymph node biopsy? This is now the era is coming into more and more conservative surgery and avoiding late complications or side effects of the radical surgeries. So these are the sentinel lymph node biopsy, but you have to address the lymph nodes in patients where is 1A1 with LVSI or 1B1, the tumors which are ideally less than 2 centimeter. Now the question is, in the era of minimally invasive surgery, whether you will go for laparoscopic or robotic surgery. Now I am sure that you know about the LAC trial. LAC trial is the trial which is a randomized control trial which proved again and again that there is no role, or there is oncological outcome is worse in patients who are undergoing minimally invasive surgery than open. So currently there is no role of doing a minimally invasive surgery or a laparoscopic approach for early stage CS cervix cases. Only indication, all the guidelines suggest you have to do a open approach. You have to take open approach, very early stage, less than 2 centimeter, no LVSI. Early, very selective 1B1 cases can be approached through laparoscopic surgery, but the patient should be counseled very well. So what are the clinical trials? There are the other trials like sucker trial, the sucker cone trials, where repeatedly this minimal and invasive surgery and its role in cervix are coming into the picture. What are the other oncological trials in the era of robot? There is RAC trial, robotic approach to cervical cancer. There is robotic versus open radical hysterectomy for early stage cervical cancer. There is launch trial, where this launch 1, 2, and 3, it is a non-inferiority trial, which all the studies are ongoing trials. Okay, so do I have time? So I will then quickly go ahead and describe the second specimen.
Dipanita.
Hi, sir. Yes, sir.
Past 12 minutes.
Yeah, I have started from 1:40. So if I can proceed, or else I will take it in next class.
Late, and the quiz is our team is already waiting also. And it will be 3 p.m. and it will be abnormally late. Okay. So I think that's the second specimen another day. If we invite you for another day.
Yes, sir. I am absolutely fine with that. So this is just a this is the ovarian specimen you will be discussing in our next slide, next class maybe.
Yeah, yeah.
So anyways, Hafizur has told me to take it in 2 or 3 classes. I don't know whether, I think 3 classes should be good enough. So because the CCS cervix is a large specimen and there are many questions.
It's very also.
Dipanita, we can cover up in the next class if required, no? Yes, sir. Because we will have it again.
Yes. Yeah, maybe we will. The next class would be on ovary.
Yeah, I think that is better because they need to focus on this after a huge information to the students.
I think it's like, it's difficult to do specimen class through PowerPoint because it is mostly the real time you take the specimen, hold the specimen and discuss.
Yeah,
so I hope I have done justice.
But you have done very well. You have done excellent description and discussion and almost elaborate discussion. So nothing can come beyond this. I think that we will go into the quiz mode now because thank you very much, Dipanita. Going to take your class very, very quickly. I mean, within 1 or 2 weeks only. Next month, okay?
Yeah, sure.
So I think
Thank
that will
you,
be
sir.
okay.
Thank you, sir.
So the time to invite the quiz team. The quiz is on hypertensive disorders in pregnancy, and the quiz conducted will be Dr. Archana Kumari, our chairperson, FOGSI Quiz Committee, and Dr. Mahima Lalwani. Are you ready with the...
My screen is visible. I have already shared the screen.
Oh, okay,
Is
okay.
it visible?
It's visible. It's visible, yes. The app is visible. I can see that. Have you invited the participants?
Yeah, I'll just share the...
Abhijit, are you there?
Is my screen, is the Kahoot pin visible?
Yeah, Kahoot screen is visible now. Waiting for participants is showing.
PIN number is also there.
PIN number is there. I hope that
So
the
participants, we are waiting for the participant to join. Mahima, are you there?
Yes, ma'am, I'm there. Even the QR code they can scan.
Yeah. So you can just guide them how to join. They can just put the game pin or they can just...
Yeah, so we have
can see
multiple participants. Yes.
Now having
we have joined
participant coming in.
5, 6.
Yeah, they just need to give a nickname and then join via the QR code. That is.
So I would request that you don't join with nickname because it is very difficult to identify at the end who is null, who is SA. So at least you can write your first name, please.
Yeah.
I think some of them are writing the first name. Bhargavi, right, for instance. Lahori is, for instance. Nirosha, Shoboshachi.
Yeah, they can choose the emoji of their whatever.
Yeah, but it becomes very difficult at the end to identify them.
I like the emoji with the helmet.
So I think it is 14:18. I will start right at 14:20. I think 2 more minutes I will wait. Right, sir? Hello? Mahima, am I audible?
Yes, ma'am, you're
Yes,
audible.
you're audible, Archana.
Yes, ma'am.
Okay, okay.
Were you saying something, or Archana?
We have
No,
about
I was
41
just
participants.
telling we will wait for just
Okay.
2 minutes more and then I will start. So we have 48 participants.
It should be okay, no? Or do you wait for 50?
Yeah, we'll wait for 2 minutes. 1 minute. So we already have 48 participants. Nice to see this huge participation. And let us see whether they are able to remain till the end of the game.
Because it is an interesting topic actually. Because the topic is very interesting.
So we have 49, 50 are logged in and we are going to start today's quiz. I'm here with my quiz committee member, Dr. Mahima Lalwani. Thanks to ICOG team, Dr. Sheila Mane, Dr. Ashish Mukhopadhyay sir and Dr. Hafizur for giving the quiz committees on it every second Sunday of the month. So here we start the quiz. Hypertensive disorders of pregnancy, preeclampsia. So 3, 2, 1. And there are 30 questions. So here is the first question. A condition where BP of the pregnant woman remains within normal range but acutely increases from own baseline. Is it delta hypertension, alpha, omega, or beta hypertension? So the correct answer is delta hypertension, and 41 of you got, of all of you got it right. It was a relatively easy one. But let's go to the scoreboard. Satvi is at the top, followed by Nirosha and Tiger. Next question. Which of the following is not a part of Mini Pierce model for predicting preeclampsia? Systolic blood pressure, gestational age at admission, parity, serum creatinine. So answers are rapidly pouring in. We have 7 seconds to go. So the correct answer is serum creatinine. Mini Pierce model is mainly based on the clinical parameters. Scoreboard showing a little change. Nirosha now at the top. Next question. Which of the following clinical trials does not deal with hypertensive disorders of pregnancy? Hypertet 1, Hypertet 2, Phoenix trial, or is it Truffle trial? So the correct answer is Truffle trial related to fetal growth restrictions. So most of you have got it right. We move on to the fourth question. A 24-year-old multigravida with twin gestation and history of PMOS, now it is not PCOS, has a mean arterial pressure of 90. So what is her gestosis score? Is it 4, 5, 2, or 3? So the correct answer is 4. Half of you got it right. The scoreboard, Satvi again at top. Fifth question, identify the person who made a significant contribution to basic elementary diagnosis of hypertension and pregnancy. So here's the image and you have to identify the scientist. Weinstein, Virchow, Korotkov, or Rocky. All the answers have come and 27 people got it right. It is Korotkov. We were discussing Korotkov's sounds during the case discussion. Scoreboard, Nick is now at the top. Sixth question. A 35-year-old primary gravida with chronic hypertension conceived by IVF, her renal artery Doppler shows this picture. So actually one part of the question is missing. Which of the drug is contraindicated? So the correct answer is Ramipril. I don't know who is V, but he is the top, he or she. Question number 7. What is the hallmark lesion of renal involvement in pregnant women with preeclampsia? Is it acute tubular necrosis, Kimmel-Steele-Wilson lesion, glomerular epitheliosis, or glomerular endotheliosis? It's an easy one actually. So the correct answer is glomerular endotheliosis. There is endothelial dysfunction, and most of that is why, because it was easy, most of you got it right. Scoreboard again, Dr. V or whoever is he or she is at the top. Let's see the next question. All except which of the following increase a women's predisposition to develop preeclampsia syndrome? This is not a multi-select type. Obesity, nulliparity, smoking, twin pregnancy. Except. Uh, 39 answers have come. So the correct answer is smoking is not a predisposing factor, rather sometimes protective. So again, we are seeing V, Sathvi, and Dr. Nick at top 3 positions. What is the threshold for protein creatinine ratio to qualify as significant proteinuria? 40 milligram, 10 milligram, 20 milligram, or 30 milligram per mole? Per millimole. So we have got all the answers. We still have 3 minutes to go. So the correct answer is 30 milligram per millimole. Almost all of you got it right. This was a basic question. Again, the scoreboard remains almost same. According to NICE guideline 2019 for hypertensive disorders in pregnancy, what should be the target BP? 130 by 90, 135 by 85, 140 by 85, or 120 by 80? Again, a very basic question, and we have got almost all the answers in, and 51 of you got it right. It is 135 by 85. Scoreboard almost same. Next question. Which angiogenic marker ratio is currently used for prediction of preeclampsia? AFP, placental growth factor, endothelial growth factor, placental growth factor, SFLT, and placental growth factor, HCT, PAPA. The ratio. Okay, the correct answer is SFLT and placental growth factor ratio. Almost all of you have got it right. So the scoreboard again remaining almost the same. Next question. Where does the earliest pathological change in preeclampsia occur? Placental trophoblastic invasion, maternal myocardium, maternal kidneys, liver sinusites. It was again an easy one. 1 minute, 1 second to go, and the correct answer is placental trophoblastic invasion. Almost all of you have got it right. The scoreboard also remaining on the same. Question number 13. What does full Pierce model predict? Risk of gestational diabetes, maternal complication and preeclampsia, preterm labor, central abruption only. So the correct answer is maternal complication and preeclampsia. This was again an easy one. The scoreboard is not showing much of change. They're consistent in their performance. So is question number 14. Which complement pathway has been implicated in the pathogenesis of severe preeclampsia? Classical pathway, intrinsic pathway, lectin pathway, or alternate pathway? Mm, 6 seconds to go. Well, the correct answer is alternate pathway. This was a little confusing. So I think only 18 of you got it right. Let's see the change in scoreboard. It's not changed. Next question, 15. The CHAP trial concluded that treating mild chronic hypertension in pregnancy reduces need for cesarean section, maternal seizures, postpartum hemorrhage, or preterm birth and adverse outcome. Okay, the correct answer is preterm birth and adverse outcome. So we are done with half of the quiz. I invite Dr. Mahima for conducting the next round of quiz. Mahima, are you ready?
Yes, ma'am. I'm good.
So the scoreboard again remaining same. So here is question number 16 for you.
Yeah. So the question number 16 is the Press syndrome and eclampsia predominantly affect which parts of the brain? Options: parieto-occipital, frontal, basal, or temporal. We have 15 seconds with us. Yes, the correct answer is parieto-occipital. I think most of them you've got it right. 47 of us. Can we have the next question, ma'am? The scoreboard is again showing V. So we have actually 3 Vs with us in the participants. Let's see which V is winning. We'll be able to find out that soon. Moving on, question number 17. How does magnesium sulfate primarily act? So we're looking at which receptors. Is it the sodium channel blockade, GABA agonism, NMDA, or it is the dopamine inhibition? Yeah, the correct answer is the NMDA receptor antagonism. It is basically the voltage dependent antagonism that is there. So most of them have given the correct answer, 47 of us. That's a good one. Now the scoreboard, we are really eager to know which V is it actually. Okay, moving on to the next one. Question 18 by 30. A woman with severe preeclampsia, sudden blindness she develops, but with a normal fundoscopy. So what is the most likely diagnosis? Cortical blindness, optic neuritis, retinal detachment, or it is the vitreous hemorrhage. Remember, she has a normal fundoscopy. Yeah, so the correct answer is cortical blindness and not retinal detachment. This was the confusion that most of us get it. So moving on, 29 of us have answered correctly. The changes in the scoreboard are evidently seen. We have Dr. Satvi with us with the highest score, 19 on 30 question, which has the double points. Read this question very carefully. Rule of 6 for the magnesium toxicity refers to loss of reflexes at what serum magnesium level? 4, 6, 12, or 9? Please read through it. It is milli-equivalents and not millimoles. So we have 10 seconds left for us to answer. The rule of 6, it shows. Correct. So the answer to this is shown. 24 of us has answered correctly. In milli equivalents, we have to calculate that. Ma'am, can we have the next this thing? Yes,
Yeah.
Satvi winning again. Next we have question 20. Double points again. Patient with severe preeclampsia and pulmonary edema, which is the preferred antihypertensive? The options are nitroglycerine, methyl dopa, hydrolysine, or labetalol. That's an easy one. We are focusing on PIH with pulmonary edema. Four people have already answered, and the correct answer is nitroglycerine. As it read in the question, with pulmonary edema and preeclampsia, the choice becomes nitroglycerine. Moving on to the next question. Before we go, Satvi is winning on the top. Satvi has a pirate emoji. Surely she definitely has been the pirate through all of us. Next question, 21 by 30, double points. Epigastric pain with a patient of severe eclampsia. This includes stretching of what? It's the diaphragm, peritoneum, Glissen's capsule, or the gastric mucosa. Yeah, most of them have answered, and it's perfect, pitch perfect answer. It's the Glissen's capsule.
Perfect answer. All of them have got it right.
Pitch
It's
perfect. I
basically
think the
UG
diagram
question.
also represented that matter. Yeah. So moving on to the next question. Satvi with 18,600 points, Bhargavi with 17,000, and then we have Nirosha with 16,940 points. 22nd question, double points for the same. Easy. Which electrolyte abnormality will potentiate the Maxalf toxicity? Hypercalcemia, hypernatremia, hyperphosphatemia, or hypocalcemia? We require pitch perfect answer for this as well. 3 seconds left. 1. And the answer for this is hypocalcemia. Yes, we have to understand that there's a high extracellular magnesium levels. They suppress the parathormone, which leads to this hypocalcemia. So can we have the next question, ma'am? The scoreboard, it goosed up and changed. Satvi with highest 20,000, then Nirosha and Suchi. So our next question, 23 by 30, asking for double points. Strongest predictor of adverse fetal outcome in preeclampsia. There are no multiple options for this. Single option, which you feel is the strongest one. Maternal headache, gestational age, severity of edema, and the degree of proteinuria. 35 people have already answered. 5 seconds to go. Strongest predictor of adverse fetal outcome. Pitch perfect. 48 have answered correctly. It's gestational age at onset. Thank you, everyone. Moving on to the next one. The scoreboard, the pirate is winning, followed by the king bunny that we have next. Satvi, Dr. Satvi on top. The next question is 24 by 30, seeking double points. Which drug is useful for refractory postpartum hypertension but is avoided antenatally? I think the Kahoot. Kahoot has been kind to all of us in this question.
I don't know how this is take the image. I need it. Let's see what's the response.
Okay.
Still, there are some lost
Still,
answers.
there are 4 plus 1 plus 2 people who didn't give weightage to Kahoot. So the answer to this is
Because
inadequate.
AI is doing so many things, takes the image automatically.
Basically, it's the ACE inhibitors, that is enalapril, that is there, which is actually avoided antenatally, but it's the best drug that can be used for a
We were
refractory
discussing this
postpartum.
thing. Dr. Ashish Mukhopadhyay discussed this thing in case discussion
Yes,
also.
yes, ma'am.
So Satvi is again at the top.
Yes.
Last few questions.
Last few questions. 25 by 30. Most common cardiac adaptation in pregnant women with chronic hypertension. So the options are dilated cardiomyopathy, aortic stenosis, right ventricular failure, or concentric left ventricular hypertrophy. Yes, the answer to that is concentric left ventricular hypertrophy. Most of them have answered correctly. Moving on to the last few questions. Before that, a look at the scoreboard. It remains the same, 3 in a row. Okay. Next, we have 26th question, seeking double points. Earliest coagulation abnormality in severe preeclampsia. Without options also, we all know this. Low fibrinogen, elevated APTT, thrombocytopenia, or elevated PT. Three seconds left. Yes, the answer to that is thrombocytopenia. 49 of us have already answered that correctly. That's great. Moving on to our scoreboard now. Nirosha has topped again. The king bunny is on top. So great. So moving on to the last three questions. Seeking double points again. The Aspirate trial utilized in which screening strategy for preeclampsia prediction? It is a combined first trimester screening model, or it's the biochemical markers, or it's the uterine artery doctor alone in that, or it is the maternal history. So what screening strategy has been taken care by the Aspirate trial? Yes, the answer to that is combined first trimester screening model. So basically all the combined model is utilized in this, not just different alone. Moving on to the next question. So Nirosha has been with 28,000 points. The last three questions. Which of the following explains the pulmonary edema in severe preeclampsia? Is it the hypovolemia alone, or the bronchospasm, or the reduced oncotic pressure and endothelial leak, or is it the increased cardiac output only that causes the pulmonary edema in severe preeclampsia? Yeah, that is amazing. It is the reduced oncotic pressure and the endothelial leak that explains the pulmonary edema in such cases. Can we have the next? The scoreboard has changed again. Satvi getting up with 29,000 points. Moving on. The second last question for the quiz. We have in HELP syndrome, the Tennessee classification requires a platelet count below. It is the Tennessee classification 50, 1 lakh, 1.2 or 1.5. They've already gained around 40 answers till now. 10 seconds to go. Yes, the correct answer to this is the Tennessee classification that has a platelet count of below 1 lakh. So can we see the scoreboard again? The Satvi winning with 31,000, followed by Bhargavi and Dr. Suchi. Now moving on to the last
question.
Yes. When is aspirin prophylaxis for preeclampsia prevention ideally started? 16 weeks, 8 weeks, 24 weeks, 12 weeks. Last 15 seconds for the quiz. The answers are pouring in. We've already got 55 answers till now. Correct. So the correct answer to this is 16 weeks. Most of us usually think it's 12, but the guidelines still document as 16 weeks when the aspirin prophylaxis for preeclampsia ideally should be started. Archana ma'am, I think that finishes the...
Yes, that finishes. Let's see the podium now.
Yes.
Podium will be ready.
That's great.
So we have Satvi at top, followed by Bhargavi and Suchi. And I don't know who was B, but anyway, it's not at the top of the podium. So let's go back to our screen. Congratulations to all the winners. Actually, we cannot directly interact with them, but they can actually follow us.
Hello.
Ma'am, I think there is a network loss.
Yes.
Yes. So we congratulate all the winners and thank you everybody for this opportunity. It was great conducting. Yes. I think ma'am had some issues with the network. but truly enjoyed the pirate and the king bunny one, and we are extremely happy. Everybody took part in it extremely enthusiastically.
Thank you, Dr. Archana and Manjula. And actually, I think Sachi and Bhargavi are from AMC.
Yes, ma'am.
Thank you so much.
Thank you, ma'am. Thank you.
Yeah. Thank you, Dr. Archana Madam and Dr. Mahima for wonderful conduct of the quiz.
Thank you,
And,
sir.
Yeah, something went
congratulations
wrong
for-
with my laptop exactly at the time,
Yeah.
but I finished it off. I'm joining through mobile. I don't know what happened. Sudden, I think network gone, and I joined through my mobile hotspot.
It's network problem, ma'am.
Yeah.
Yes. So that is why Mahima was at the backup.
Yes.
Okay. Thank you so much, ma'am.
All right.
So
Thank you, everyone.
on behalf of the ICOG, I'd like to thank the FOGSI president and the chairperson, ICOG, and with my
Hello, Hafizur sir?
Yes. Yes.
Sir, you are not perfectly audible. Your network is not proper, sir.
Yeah. It's not audible. Yeah.
Dr. Archana Kumari, Dr. Sahini Bhattacharya, madam, and
Again, it's gone.
Yeah, thank you, Hafizur, for taking so much pain every second Sunday and coordinating with all the faculty, that deciding the topic, the teachers. That is really wonderful. Thank you, Somini ma'am. Whoever is
Thank
visible, thank you, Mahima. Thank you, all the participants of quiz and all the viewers of this PG ICOG clinic. I think it is very useful
Yes.
program for all the PGs, and it is the vision of FOGSI ICOG chairpersons and all the vice chairperson and the the office bearers. So I think Hafizur has lost connection or something. There might be network issue.
Yes.
yes, ma'am. Thank you. I'm traveling a bit.
So I proposed vote of thanks on behalf of you.
Yeah, thank you so much,
Please
ma'am.
give thanks to ICOG.
Thank you, ma'am. You are like, you have been consistently like our host from the last for this session, Archana, ma'am.
Yeah. Thank you, the president of FOGSI,
thank-
ICOG, and then Hafizur, definitely, and Dr. Archana and Dr. Mahima. Thank you all. I think our students also are the part of winners of from AMC. Thank you so much.
Oh, that's great.
Yeah.
Yeah, thank you, ma'am. Congratulations for all your wonderful performance of your students.
Thank you, sir.
So those who were presenting the case,
Thank
they
you
all
so much,
they
sir.
only won.
Saloni, you can stop recording.
Yes, sir.
Okay, bye. Thank you, Mahima.
Thank you so much.
Okay, ma'am. Thank you so
Bye.
much.
Thank you,
Bye-bye,
Hafizur. Ma'am. Bye.
Okay, bye-bye.
Thank you.
ma'am.
So
Thank
with
you
that,
so
we are
Yeah, please.
yeah, sir. Thank you so much for joining today's session. So with that, we are closing this meeting. Thank you.